Reflex, you can just imagine like a baby, you try to feed some medicine, which is a better medicine. So the moment you put the medicine, the no spoonful of that liquid into the mouth of the baby, immediately it comes out. So that is one example of gag reflex. The other example is try putting something which is bitter into your own mouth, and it'll happen that there'll be a sudden spasm of palatal, pharyngeal, laryngeal muscle. And why is that happening? Because our system, respiratory tube as well as the gut tube, they don't want anything which is dangerous or poisonous to enter the body. So this going to spasm. This is gag reflex. Now, if you say it is a protective reflex and it is something to do with putting things into mouth, especially at the oropharyngeal isthmus, then how does it work? Means how do you check it if you want to check it as a clinician? What you can do is you can look at page number 100, and you see what we are doing is we are trying to touch the posterior pharynx wall to elicit the gag reflex, which is pharyngeal gag reflex. You could also elicit the gag reflex by palatal way. Now you can touch the palate, which is you can see the uvula here, soft palate. You could touch the palatine tonsil also. You could touch the posterior one third of tongue also, which is oropharyngeal isthmus. Oropharyngeal isthmus. Isthmus means junction of the oral cavity and the oropharynx. So, what exactly are you trying to stimulate? What I'm trying to stimulate is ninth nerve, because it is the ninth nerve which is sensory here, and it is the ninth nerve which will be supplying oropharyngeal isthmus. Now, when you say it is supplying oropharyngeal isthmus, not only that, it also supplies the posterior pharyngeal wall. So, you are trying to stimulate either the posterior pharyngeal wall, or you were trying to stimulate the posterior one third of tongue, which is at the isthmus. You could also stimulate the palatine tonsil, and you could also stimulate the palate, soft palate. The point is, all this area is being supplied by the same nerve. So, what is the territory, sensory territory of ninth nerve? The sensory territory of ninth nerve is posterior pharynx wall. You are stimulating that. Or it could be the soft palate, or the palatine tonsil, or posterior one third of tongue. That is why there's a description of referred otalgia sometime. So, what is referred otalgia? Any problem in this region, maybe soft palate, you have patient with tonsillitis, or there's a tumor on the posterior one third of tongue. There's pain in the ear. Why there is pain in the ear? Because ninth nerve also supplies tympanic plexus in the middle ear cavity, and middle ear cavity there can be referred pain. Now, what is this referred pain? See, any pathology which is in the posterior one third of tongue or palatine tonsil, like tonsillitis or soft palate, even posterior pharynx wall, you can have patient with referrotalgia. What is that? Means the pathology is in the oropharyngeal isthmus, but the patient is feeling pain in the ear. But why? Because the tympanic branch of ninth nerve supplies tympanic plexus, middle ear cavity. So, so there is a concept of referred pain. And what is referred pain? Referred pain you can learn by the way that if this is a central nervous system and a nerve is supplying two regions, carrying sensation from two regions, there is a convergence of the sensation, and this is convergence theory of referred pain. Maybe it is ear or maybe oropharyngeal isthmus. So the brain is unable to decipher that where the pain is coming from. Maybe the pain is coming from oropharyngeal isthmus, but it is converging on the CNS, and brain is unable to understand that whether the pain came from oropharyngeal isthmus or from the ear. So, a pain of the oropharyngeal isthmus can be felt as if coming from the ear. Can it happen the other way around? If I have a case of chronic suppurative otitis media and there is pain in the ear, can that pain be felt on the tongue? Yes, of course, it can be. So, ear pain can be felt on the tongue also. Yes, because any sensation which is coming from ear is reaching a point which is also a converging point of the oropharyngeal isthmus. So, pain of ear can be felt on the tongue pain can be felt on the ear, because this is some brain confusion, and it is called convergence theory of referred pain. Yes, you remember that. Okay, what about gag reflex? What is the pathway? As you talk about the pathway, you will see that when you were touching the ninth nerve, when you are touching the ninth nerve, you will find you are activating a nucleus. So ninth nerve you have activated, and then nucleus tractus solitarius. Nucleus tractus solitarius has upper part. The upper part, the tip is for taste. The tip is for taste, but you are carrying this information to the bottom. So it will go to the bottom or lower part. So remember this nucleus tractus solitarius, which is a sensory nucleus. It is in the lateral medulla. If you remember, we have talked about nucleus tractus solitarius in the lateral medulla. So this is nucleus tractus solitarius, which is having two parts. Upper part, tip is for taste, but lower part, as you are stimulating, visceral sensations or these kind of sensations can reach there. So as we have stimulated the ninth nerve, the sensory information goes to nucleus tractus solitarius. Yes. The bottom part. Yes. What will happen next? The nucleus tractus solitarius will then activate the next nucleus. This was a sensory nucleus. Will activate the motor nucleus. And what's the motor nucleus? Nucleus ambiguous. So nucleus ambiguous is the motor nucleus and will be activated. This is the pathway. So what is nucleus ambiguous like? It is the number 9, 10, and cranial part of 11, supplying the muscles of pharyngeal arch 3, 4, 6. And which muscles develop in arch 3, 4, 6? They are the muscles of palate, pharynx, and larynx. And what do the muscles of palate, pharynx, and larynx do? They are working for speech and swallowing. Their function is speech and swallowing. This is the normal thing. So, what is going to happen right now? See, we have stimulated the area of ninth nerve, which was carrying the information to the lower part of nucleus tractus solitarius, which was then activating the motor nucleus, which is nucleus ambiguous. Both of them are in the lateral medulla. Both of them are in the lateral medulla. They'll be compromised in lateral medullary syndrome, if you remember. So, lateral medullary syndrome, are you trying to say in Wallenberg syndrome, there'll be loss of gag reflex? Yes, there is loss of gag reflex because none of the nucleus is working, neither sensory nor motor. And there'll be difficulty speech swallowing. Yes, there'll be difficulty speech swallowing also because there is a paralysis of muscle palate, pharynx, larynx. So, as we continued the discussion, we understand that nucleus tractus solitarius and nucleus ambiguous both are present in the lateral medulla. There'll be compromise in lateral medullary syndrome or Wallenberg syndrome. There'll be loss of gag reflex. But anyway, tell us the normal gag reflex. We have stimulated ninth nerve. It was activating nucleus tractus solitarius. It was activating nucleus ambiguous. Now what will happen? Nucleus ambiguous is the number 9 to 11, cranial part of 11, which is controlling muscles belonging to pharyngeal arch 3, 4, 6, which are muscles of palate, pharynx, larynx. They are for speech swallowing. They'll be undergoing sudden spasmodic spasm. So, sudden spasmodic spasm. Yes. And you'll see the larynx and pharynx get closed. They're closed. They don't want any harmful thing to enter either the respiratory tube or gut tube. There is a sudden glottal spasm and sudden pharyngeal spasm. You don't want to let enter any harmful substance into respiratory tube or gut tube. That is what is the reflex. Okay, understood. Which nerve was doing this? Which is the motor nerve? Motor nerve is, of course, ninth nerve, 10th nerve, and 10th nerve carrying the axons of cranial accessory nerve, because cranial accessory nerve do not come by itself. The cranial accessory nerve, you have to understand, is carried, its axons are carried by branches of vagus. And as you are telling that the cranial accessory nerve branches or axons are carried by the branches of vagus nerve, it is called vagus accessory complex. This is vagus accessory complex. It is the axons of cranial accessory nerve, but they don't come themselves. They need somebody. So who is carrying the axons? The vagus nerve. Branches of vagus they'll carry. And which branches of vagus? Mostly they'll be pharyngeal branches of vagus. So they are pharyngeal branches of vagus and laryngeal branches of vagus. So you are trying to say cranial accessory nerve do not come itself to larynx, pharynx to control these muscles of palate, pharynx, larynx. No. But it is sending axons via the vagus nerve, so that vagus accessory complex is there, and which will be then giving some, the vagus will be giving some Pharyngeal branches, laryngeal branches. Yeah, it is the branches of vagus, and it is called vagus accessory complex. Vagus accessory complex. Anyway, so once you have this information, you can proceed further and look at this diagram also. What is this diagram about? I have a patient. I told the patient to open his mouth, and I told him, say, ah. What did you say? I told the patient, say, ah. First, you demonstrate yourself to the patient, then tell the patient to do it. So, as the patient says, ah, what will happen? What will happen is there'll be contraction of the palatal muscles. In that, there's a contraction of the palate, and palate gets elevated. That is normal. So when you tell the patient to say ah, there'll be contraction of palate and palate will be elevated. Yes, even the uvula will be elevated. What is uvula? Uvula is a downward projection in the midline, and it is part of the soft palate, and it is in the midline, and it will also be elevated. You mean to say this is palate and this is uvula, and as you say ah, it'll be contraction of the palatal muscle. The palate will elevate and uvula will always elevate, and it'll be in the midline. Yes, but I don't see it is in the midline. I find this uvula is deviating. It is deviating. It is deviating to right side. So what is the problem? The uvula is deviating to right side. What is the problem? It is not in the midline, and not only this uvula. Let me rub off. Is deviating to right side. You see, this sided palatal muscle is sagging down, sagging down. This is contracting, going up. So right sided palate is contracting up, it is going up. But this side palate is sagging down. What is happening here? So the problem is we have 10th nerve not working on left side. And if the 10th nerve is not working on left side, if the 10th nerve is not working on left side, then the left palatal muscle cannot elevate. They will sag down compared to the normal side, right side. Right side is normal, it is elevating. So what is the problem? Problem is that normally this is how the uvula is elevated. But if you are telling that left muscles are not working, they are sagging down, and the right muscles are normal, they are pulling the palate up, somehow the uvula will deviate to the normal side. In that process, uvula deviate to the normal side, pulled to the normal side. Okay, so you are telling that if I find a patient after saying, ah, that uvula is deviating to right side, the contralateral vagus nerve is gone? Yes. Okay. And I will also find that normal side, the palatal muscle are going up, but the affected side, they sag down? Yes. Because vagus nerve is not there, then we will move the palate. Move it. If it is not moving up, then relatively it will appear to sag down. Muscles will be flaccid. Vagus nerve is lower motor neuron. If lower motor neuron is not working, muscles will be flaccid and they'll sag down. Okay, got the point. Now, the problem is, yes, Aditya, that is correct, left-sided lesion. So the problem is this question came and we were unable to find that what should be our answer. Why? What is the problem in the question? Page number 98, the workbook given to you. This patient is presenting with fractured skull base. Yesterday also, I think Deepak was asking about this battle sign. Battle sign is basically a fracture at the skull base. And it can be middle cranial fossa, it can be post-sacral fossa also. But preferably, if both options are there, you should go for middle cranial fossa as your ENT professor has told you. But it is, again, we were telling that post-auricular artery that bleeds and there'll be a lot of blood here, ecchymosis. The skin color changes from brown to green to blue, black. So, like that, like that. Okay. So, sir, can't the cranial nerve 9 alone can compensate the deviation? 9 alone. 9 is supplying only, first of all, ninth nerve is the nerve of third pharyngeal arch, and it is having only one muscle, which is called stylopharyngeus. Stylopharyngeus is elevator of pharynx. It doesn't work on palate. Let me take you back to this diagram which we were discussing. In this diagram, though I mentioned that nucleus ambiguous is having ninth nerve, but remember, ninth nerve is the nerve of third arch, and third arch has only one muscle. It can supply only one muscle, which is stylopharyngeus, and stylopharyngeus is elevator of pharynx for swallowing, and it has no role in palate movement. So I'll repeat again. Though I told you that nucleus ambiguous will have nerve number 9, 10, 11, chiefly it is vagus axillary complex which works because ninth nerve is the nerve of third arch. Third arch has only one muscle, which is stylopharyngeus, and it is a elevator of pharynx. It has nothing to do with palate. So, as you are asking, Deepak, can't the ninth nerve alone compensate the deviation? Ninth nerve doesn't work on palate. It is sensory to palate, but it is not motor to palate. So, no, it cannot compensate. If 10th nerve is gone, we'll have this problem. Now, as we are proceeding with this question, see, these days questions are not simple. This is 21 question, year 21 INICET. They're not simple question. Yes, Deepak, welcome always. First of all, you have to understand that when there's a fracture skull base, then which nerve could have been damaged? Because fracture skull base, there are so many foramina, so many nerves. So at the temporo-occipital region, do you remember this? Temporo-occipital region, there was one foramen called jugular foramen. And in the jugular foramen, there's the number 9, 10, 11. And if there is a jugular foramen fracture, there could be involvement and we can have what is called features of Wernicke syndrome. So maybe they are talking about Wernicke syndrome. I'm just guessing. So because they are telling temporo-occipital region, petrous temporal bone and occipital bone, what is between them? Between petrous temporal bone laterally and occipital bone medially, we had this jugular foramen. And jugular foramen has the number 9, 10, 11. Not only that, it has this internal jugular vein also. Internal jugular vein is also in the jugular foramen. So there could be features of Wernicke syndrome. What is feature of Wernicke syndrome? Obviously, number 9, 10, 11 gone. There'll be some sensory loss. And not only there'll be some sensory loss, there'll be motor loss also. So what kind of motor loss could be there? There'll be difficulty speech swallowing. Why there'll be difficulty speech swallowing? Because number 9, 10, 11, nucleus ambiguous. So you understand what will be happening. There'll be paralysis of palate, pharynx, and larynx muscle. Palate, pharynx, and larynx muscle. So there will be difficulty speech swallowing. And not only that, this 11th nerve, which is in the jugular foramen, dysarthria, dysphagia, dysphonia, all those problems will be there. So not only this 11th nerve, which you are talking about, is having cranial accessory nerve, it is also cranial accessory nerve. It is also spinal accessory nerve. So spinal accessory nerve supply two muscles, and those two muscles are sternomastoid and trapezius. So even sternomastoid and trapezius will be compromised. Sternomastoid is for turning the neck to the opposite side. So patient, whichever side the fracture was, will not be able to turn the neck to the opposite side. And then there'll be difficulty shrugging the shoulder because trapezius is not working. There'll also be difficulty in overhead abduction because that is the job of trapezius. So trapezius is basically doing two functions like shrugging the shoulder, and also it is basically overhead abduction. So let me repeat the things again. See, as the presentation is, that patient had a fractured skull base. There are so many foramina could be involved, but they're telling temporo-occipital region. Difficulty in speaking, that could be dysphonia, dysarthria. Dysphonia is better, post-trauma. So with that, I'm thinking not only speaking, but there will be problem with the swallowing also, difficulty speech swallowing. And what should you test? That is the point. So we are talking about jugular foramen fracture. We are talking about number 9, 10, 11, and also internal jugular vein, which could be features of Wernicke syndrome. Wernicke syndrome can have sensory loss in the territory of nerve number 9, oropharyngeal isthmus gone, and posterior pharynx wall gone. 10th nerve also supply posterior to 9th nerve. So 10th nerve supply epiglottis area. So that sensory loss. 11th nerve is pure motor. It has cranial accessory and it has the spinal accessory. Spinal accessory has to supply sternomastoid trapezius. So there'll be difficulty in turning the neck to the opposite side. If lesion is right side, the patient cannot turn the neck to the opposite side. Sternomastoid not working. Trapezius not working, so difficulty shrugging shoulder. And overhead abduction also. If you want to do overhead abduction, the trapezius work with serratus anterior. Serratus anterior and trapezius, they work for overhead abduction. It will be a problem. All those could be features of Wernicke syndrome. Okay, so you are asking what should I test? Yes, and for that, now as we magnify the area, you can see this is the area above the nose. You can see the brain also. This appears to be frontal lobe because it is sagittal section. That appears to be frontal lobe, and this is the nose. That is the tongue. This is the cribriform plate of ethmoid bone area. So if it is a cribriform plate of ethmoid bone area, cranial nerve number 1, olfactory nerve, they are asking maybe. So they are asking because skull base, they are telling there's a problem with the skull base. So maybe there is some fracture at the cribriform plate of ethmoid bone and cranial nerve number 1 involved. But this is not clinical feature of something wrong with smell. Okay, so could be the tongue involved. This is the bulk of tongue. Mostly it is genioglossus muscle. Remember, bulk of the tongue is made by the muscle, which is genioglossus. So, are you talking about a problem of genioglossus, tongue? No. So, are you talking about this area, which is, you can see, vocal cord? This is vocal cords. Vocal cords, how do you know? Because you see, false vocal cord, this is true vocal cord, and larynx, sinus of larynx is evident, black color. So sinus of larynx is evident where the arrow is pointing. Yes. And false vocal cord, true vocal cord. You are trying to check the vocal cord by doing indirect laryngoscopy. Yes, indirect laryngoscopy you can do and you can check the vocal cord. But then if I'm doing that, I'm checking for cranial number 10. Yes, of course, you are checking for cranial number 10. What is this area now? This is the B, marker B, and it is uvula. How do you know it is uvula? Because you can see this is the tongue, this is old cavity, hard palate is anterior, soft palate is posterior, midline projection, this is uvula. So it is a part of the soft palate uvula. Yes. And what is this area? What is this? This is epiglottis, lid over the larynx. Sometimes they'll mark that also. So lid over the larynx, epiglottis. And this is the larynx, the vocal cord. This is the tongue. And that is vertebral column with intervertebral disc. Yes. That is spinal cord in the vertebral canal. Yes. That is the brain stem. Right. Midbrain, pons, and medulla. Cerebellum. Dural fold here. Falx cerebri. Straight sinus here. So just get some idea. Straight sinus here at the base of falx cerebri, which is a dural fold separating the two cerebral hemispheres. This is falx cerebri. Okay, so let us come back here. What should I answer? A, B, C, or D? What do you think? Tell me now. Deepak, Rahul, Akshay. So, yeah. So B is the answer. But why B is the answer and why can't you take your answer? Yeah, B is better than D. Yes, Deepak. So B is better than D. But why B is better than D? See, when you are testing the uvula, you can just touch the uvula for gag reflex. And when you touch the uvula for gag reflex, not only you will be checking ninth nerve, but you will also be checking the 10th nerve because gag reflex, you are checking for gag reflex. If you just check for vocal cord, you are checking for 10th nerve only. So it is better that we check for nerve number 9 also, 10 also, and 11 also. So you want to check nerve number 9, 10, 11. This is checking just the 10th nerve. But there, if you touch, then you are checking 9th nerve as well as 10th nerve and 11 cranial part. So somehow in all these options, as you are telling B is a better answer than D. I have given the explanation in the workbook also. You can read and go through it. It was a controversial question, but according to me, the better answer is choice number B. You better touch the uvula. Now, you touch the uvula. It is not that you are going to say the patient, ah, because if you say, tell the patient, say, ah, then you are checking for 10th nerve. You have to touch the uvula. That is how you will be checking for number 9 as well as 10, because 9 will be sensory and 10 will be motor. So you're checking sensory as well motor. So that is how you deal with the questions which are coming in the present times. Now, this is also one of the latest question, as you see page number 101. So when you look at page number 101, you will find in the workbook INI-CET May 2023, not very long back. So match the following with their corresponding action. Let us see what is this mandibular nerve. Mandibular nerve is sensory motor. It will supply skin on the mandible. It also supply lower teeth area, and it will also be the muscles of mastication developing in first arch. So it will control muscles of mastication developing in first arch. So I believe this is the best answer, because muscles of mastication develop in first arch, and first arch nerve is mandibular nerve. Okay, so what about facial nerve? Facial nerve is the muscle, it is the nerve of second arch, so muscles of facial expression, but it is also supplying some glands on the face, and it is also carrying taste sensation from the anterior two-third of tongue. So as you say, facial nerve carry taste sensation from anterior two-third of tongue. What I see is it is written anterior one-third of tongue. What is this? Anterior one-third of tongue. No problem. Let us mark it here only, because it carry the sensation from anterior two-third of tongue, but even one-third of tongue, of course, it will carry. Then what about glossopharyngeal? Glossopharyngeal, as I told you, only one muscle supplies, stylopharyngeus, elevator of pharynx, but it is sensory to so much of area, oropharyngeal isthmus, and it is not only general sensory supply, it is also carrying taste. Carry taste from where? Posterior one-third of tongue. And if you have taste bud in the soft palate, the taste of the soft palate also in that area, oropharyngeal isthmus, is carried by glossopharyngeal. So are you trying to say glossopharyngeal nerve is to be marked with the taste of the posterior one-third? Journal sensation also. Yes, journal sensation or taste from posterior one-third, because posterior one-third of tongue develop in third arch. So we'll be talking about all this, but I'm trying to reach the answer here. Third arch, you have nerve, glossopharyngeal, and posterior one-third of tongue develop in third arch. We'll see the detail of developing tongue. And spinal accessory nerve, of course, you already have known. Spinal accessory nerve is 11th nerve, and it will control the muscles like trapezius, and not only trapezius but also sternomastoid. So that is why this is the matching. So you're telling one is D. Yes, one is D. So one is D. I have these one. Then you are telling two is C. Yes, two is C. Okay, both are there. Then three is B. Okay, three is B. Then this is the answer. So that is matching. Now, as you are telling B, uh, maybe you have not given any answer, but let us now proceed further with the mandibular nerve. So, what about mandibular nerve? First of all, you should know mandibular nerve is the nerve of first arch. So, as it is nerve of first arch, it will supply muscles of mastication. And when you say muscles of mastication, you can remember MTM elevators. Now, what is this MTM elevators? The masseter, the temporalis, and the medial pterygoid. They are elevator of the mandible, and they will be closing the mouth, because you elevate the mandible, you close the mouth. So you're telling mandibular nerve, which is the nerve of first arch, will be supplying muscles of mastication, because muscles of mastication develop in first arch. So what are the muscles of mastication? I'm telling you MTM elevators, the masseter, temporalis, medial pterygoid, and they are elevator of mandible. As they elevate the mandible, they'll close the mouth. So then we'll open the mouth. So these are the muscles which will close mouth. And let us talk about the depressors of mandible. So there are three elevators and there are three depressors. So what are the three depressors of mandible? As you talk about the three depressors of mandible, which are going to open the mouth, you can mention here. First of all, you should say lateral pterygoid. Lateral pterygoid is depressor of mandible. Along with that, mylohyoid and anterior belly of digastric. Remember these names. They all develop in first arch. So you are trying to tell that since we have mandibular nerve here, we are talking about the first arch, nerve of first arch, supplying muscles of mastication, three elevators, three depressors of mandible, three elevators, E for elevator, MTM elevators. So masseter, temporalis, and medial pterygoid. They were elevator of mandible so that you close the mouth. Now you want to open the mouth. So there are three depressors of mandible, and the three depressors of mandible are lateral pterygoid and mylohyoid. MH is mylohyoid. And as you say, anterior belly of digastric. So what are these muscles doing? They are depressors of mandible and they will close depressor, open the mouth. Okay, so they'll open the mouth. So we are opening mouth and closing mouth. Why? Because you are masticating, muscles of mastication. Okay, fine. Can we talk about this journal sensation, taste sensation of tongue? Journal sensation, taste sensation of tongue? Yeah, let us do that. What you have to do is you have to look at the developing tongue. So this is the developing tongue. And in that tongue, you'll find there's a sulcus terminalis. And where is the sulcus terminalis? Sulcus terminalis is in the tongue, which is separating anterior two-third of tongue from posterior one-third of tongue. Okay, so you are telling that there is some sulcus terminalis which is separating the anterior two-third of tongue from posterior one-third of tongue developmentally. Yes. And you should understand there is a foramen cecum here. This is foramen cecum. And foramen cecum is also at the same level where you have this sulcus terminalis. Okay, foramen cecum is also at the same level where we have sulcus terminalis. Where it is? It is the junction of first and the third arch. Junction of first and third arch. Why? Where is second arch? Second arch do not contribute to tongue significantly. So you're telling that anterior two-third of tongue develop in first arch. Yes. And posterior one-third of tongue develop in third arch. Right. And second arch will disappear at foramen cecum. Yes. Second arch disappears at foramen cecum. And this junction is basically sulcus terminalis, junction of anterior two-third and posterior one-third. Then what about the posterior most tongue or the root of tongue? If you say posterior most tongue, which is also called as the root of tongue, that is the fourth arch. So you are mentioning now that posterior most tongue or root of tongue is developing in fourth arch. Yes, and fourth arch not only give the posterior most tongue, but it will also give epiglottis. It will also give epiglottis, the lid over larynx. Yes. So if you are telling epiglottis also develop in fourth arch, which is lid over the larynx, and also posterior most tongue and root of tongue, what is the nerve of fourth arch? Nerve of fourth arch is actually branch of vagus called superior laryngeal nerve. So nerve of fourth arch is branch of vagus called superior laryngeal nerve. Yes. So are you trying to say that superior laryngeal nerve will supply posterior most tongue and epiglottis? Yes. And what kind of sensation it will carry? The superior laryngeal nerve, which is branch of vagus nerve for the fourth arch, will be actually giving internal laryngeal nerve. Okay. And that internal laryngeal nerve will be supplying this area. Okay. And it will carry both sensation, maybe journal sensation or maybe taste sensation. So as we understand that epiglottis also have taste buds. Even epiglottis has taste buds. And of course, they will have journal sensation like touch, pain, temperature, etc. So touch, pain, temperature, etc. is journal sensation. Yes. When you say journal sensation, it means touch, pain, temperature, etc. So maybe it is touch, pain, temperature, or maybe it is taste sensation, maybe it is epiglottis, or maybe it is posthumous tongue. Since they develop in the fourth arch, they'll be supplied by nerve of fourth arch, which is superior laryngeal nerve branch of vagus, itself giving internal laryngeal nerve, and internal laryngeal nerve is supplying this journal sensation, taste sensation. Fine. What about the posterior one third of tongue? Posterior one third of tongue, you have glossopharyngeal nerve, number 9. And it is also supplying not only journal sensation but also taste sensation. So journal sensation, taste sensation, where? The posterior one third of tongue. Because posterior one third of tongue develop in the third arch. So it will be the nerve of third arch, glossopharyngeal nerve. So it will supply journal sensation, taste sensation from posterior one third of the tongue. These are the arches we have written. Okay, so if you are telling like that, I'll tell you one thing. There was this circumvallate papilla which were developing. There were these circumvallate papilla which were developing posterior one third of tongue, but they have migrated anteriorly. So who will supply them? So remember, circumvallate papilla lie anterior to sulcus terminalis in the adults. Circumvallate papilla, they lie on the anterior two-third of tongue in the adults, but they have developed in the posterior one-third of tongue area, means third arch. And since the circumvallate papilla develop in the region of third arch, that is, along with posterior one-third of tongue they have developed, they are also supplied by the branches of glossopharyngeal. So glossopharyngeal nerve, nerve of third arch, will supply not only journal sensation but taste sensation for not only posterior one third of tongue but also circumvallate papilla. Maybe the circumvallate papilla have migrated anteriorly into the anterior two third of tongue, but they are still being supplied by branches of glossopharyngeal nerve. Okay, then we will supply anterior two third of tongue. Anterior two third of tongue minus the circumvallate papilla. Anterior two third of tongue minus the circumvallate papilla will be supplied by nerve of first arch. And who is nerve of first arch? Nerve of first arch you already have discussed. It was mandibular nerve branch of trigeminal. So mandibular nerve branch of trigeminal will carry what? Journal sensation. And who will carry the taste sensation? Taste sensation somehow carried by cauda tympani nerve, branch of facial nerve, and which is nerve of second arch. Though the second arch has disappeared from the tongue, but it sends one nerve, cauda tympani nerve, which is also called as pretraumatic nerve. What is that? Pretraumatic nerve. So pretraumatic nerve, branch of facial nerve. Yes. What is it doing? It will carry the taste sensation. From where? From the anterior two-third of tongue. So let me repeat the information again. All of these are MCQs. You are telling anterior two-third of tongue minus circumvallate papilla. Yeah. Have two nerves to supply? Yes. Anterior two-third of tongue minus circumvallate papilla will have two nerves to supply. Yes. If you talk about taste sensation, then anterior two-third of tongue minus circumvallate papilla. Taste sensation is carried by pretraumatic nerve, which is cauda tympani nerve, branch of facial nerve. Facial nerve is nerve of second arch, though second arch disappear from the tongue, do not contribute to tongue significantly, but it leaves behind out branch of the facial nerve, nerve of second arch. Name is cauda tympani nerve. It is a pretraumatic nerve, and it carries taste sensation from anterior two-third of tongue. Okay. Then what about the journal sensation anterior two-third of tongue? Journal sensation from anterior two-third of tongue is, because it is developing in first arch, it will be supplied by nerve of first arch, which is nerve of first arch is mandibular nerve branch of trigeminal. Third branch of fifth nerve. Third branch of fifth nerve, mandibular nerve branch of trigeminal. Okay, what does it do? Carry journal sensation like touch, pain, temperature, etc. So remember all this information. And we have used this information when we were talking about this question here. Because in this question, page number 101, we have talked about facial nerve, which is the nerve of second arch supplying the muscles of facial expression and some glands on the face. But it is also carrying taste sensation from anterior. It is written one third, though it is anterior two third, but we don't have any other option, so we'll choose this matching with facial nerve. Glossopharyngeal nerve carry journal sensation as well as taste sensation from posterior one third of tongue. So that is how we have taken care of some information based upon the questions, and we move further. So as we are moving further, we have to talk about this Horner syndrome. Horner syndrome used to be one favorite topic of questions, entrance exam questions long back. It has reappeared. It has come again. So why do questions reappear? Questions reappear because whatever questions the examiner is asking, all the students are answering. So if all the question he's asking and students are answering, he'll explore some other area, the area which he already explored earlier. And he's thinking that students may not be aware of it. But that is why what I tell my students, you should do last 5 year questions. And once you are done with last 5 year previous year questions, you expand it to 10 years and then expand it to 15 years. You should actually work upon last 15-year previous year questions. And that will be more than enough, which you can actually spend your time upon. Like some students say, sir, doing previous year question is, I'm not very comfortable with previous year question. I want to study some theory. Are you giving some university exam that you want to study some theory? You want to read BD Church? Yeah. Is there first year exam you are giving? What are you doing? You have to do the previous year questions. Last 5 year, 10 year, 15 year. And you'll find that they keep repeating again and again and again. Okay, so what question came? It is one of the recent question which has come. I'll show you the question. But let us talk about the Horner syndrome. Do you see one thing here? Page number 104. Page number 104. Come to page number 104, which is the workbook page. Do you see there is a difference of color in the iris of this baby? This baby, there's a difference of color in the iris. There's a heterochromia iris. So they used to ask this question. That was the last thing they asked, and they stopped asking Horner. And again, they have come back. And they again will start doing the same thing because they know that people have forgotten about Horner syndrome. Horner syndrome is rare in clinical practice, but it is not so rare in entrance exam. Horner syndrome is a rare entity in clinical practice. You will never see any case of Horner syndrome ever in your life, in your practical life of being a physician, but it is rampantly asked in exams. Okay, so are you telling this is some color difference? Yes, this is called heterochromia iris and will be seen in congenital Horner syndrome. So congenital Horner syndrome, you can have heterochromia iris. Why? That I'll discuss. But here, let us talk about Horner syndrome in detail because I'm expecting many questions are coming now. They have started the process and it will continue for next 3, 4, 5 years. They'll keep asking Horner syndrome. Okay, so let us also discuss Horner syndrome. This is a patient of right-sided Horner syndrome. Let us say T1 sympathetic pathway is gone. What is that? T1 sympathetic pathway is gone. That is Horner syndrome. If you remember, in Wallenberg syndrome, there was Horner syndrome because T1 sympathetic pathway was involved. Do you remember that? When we were discussing right-sided Horner syndrome, I told you there is a descending sympathetic pathway which was coming from hypothalamus to spinal cord, hypothalamo-spinal pathway. So that hypothalamo-spinal pathway is T1 sympathetic pathway. It controls some muscles which we want to talk about, and it also controls some other areas also. So you are looking at a patient who has right-sided Horner syndrome. Can you tell, like, what is this T1 sympathetic supply normally doing? So this is the eyes, the nose, and this is the mouth. And normally, if you talk about the muscles which it is supplying, T1 sympathetic pathway, they are superior tarsal muscle, part of Miller muscle, and it is for upper eyelid elevation. So that is the job. Now you are talking about the muscles which are supplied by T1 sympathetic pathway. Yeah, not only muscles, but the area, the supply, other than muscles also. So you are telling that this T1 sympathetic pathway is supplying superior tarsal muscle, which is a part of the Miller muscle. It's a smooth muscle, I believe. Of course, sympathetic pathway, they control smooth muscles only. They control cardiac muscle also, but here you don't have any cardiac muscle. So you are talking about smooth muscle. So T1 sympathetic supply and some smooth muscles you are talking about. One of them is superior tarsal muscle, part of Miller muscle, and it is for upper eyelid elevation. Okay, so we are talking about smooth muscles here. Yes, smooth muscles. And can we know about any other smooth muscle? Yes, dilator pupillae. And what is the function of dilator pupillae? The name is telling it will dilate the pupil. Okay, name is telling it will dilate the pupil. What is the third muscle we can talk about? It is the orbitalis muscle. Orbitalis muscle is in the orbit. Yes. What is it doing? It'll push the eyeball out of socket. It'll push the eyeball out of socket. But why you want to push the eyeball out of socket? It's a small muscle and it is just protruding the eyeball out of socket. That is the job. Orbitalis is a smooth muscle in the orbit which will just push the eyeball out of socket. You just want them to be slightly outward. Okay, so you have told that these are three smooth muscles. Yes. And these three smooth muscles well supplied by T1 sympathetic pathway, right? Supratarsal muscle, podomular for upper eyelid elevation, dilator pupillae, which is dilating the pupil, and orbitalis, which will push the eyeball out of socket. Is there any supply of T1 sympathetic? Yes. It will be supplying the sweat gland here. Remember, sweat gland is the only gland which is under sympathetic system. Otherwise, all the glands are parasympathetic. All the glands are under parasympathetic system except the sweat gland, only SS. What is SS? Sweat is sympathetic. Otherwise, all the other glands are parasympathetic. Yes, SS, sweat is sympathetic. So this T1 sympathetic will supply sweat gland on the face. Yes. Okay, what else? Sympathetic system is for vasoconstriction. It is for vasoconstriction. Sympathetic system is for vasoconstriction. Yeah, that I know. Now, this much you remember. Now, what happened? Say right-sided Horner syndrome. This patient is having ptosis. Tell me why the patient is having, and it is partial ptosis. It is partial ptosis. Tell me why this patient is having partial ptosis. Very easy. This patient is having partial ptosis because T1 sympathetic pathway is not working right hand side. So superior tarsal muscle is not working. That is why there is partial ptosis. The question they asked was, LPS is normal, yes. Levator palpebrae superior is normal. That is why it is not severe ptosis. Dream, I don't know what is next to that, but you are correct. LPS is normal because LPS is skeletal muscle supplied by third nerve. LPS is normal, which is a skeletal muscle supplied by third nerve. So there is no severe ptosis, but there is partial ptosis. You are correct. But my question is actually the question which the examiner asked around 10 years back. 10 years back, the question was why there is partial ptosis. Which muscle has become unopposed? That was the question. And it is about to come anytime. So you are telling that this patient, first of all, you told it is not severe ptosis because LPS supplied by third nerve is still working. Levator palpebrae superior is still working. It is a skeletal muscle. So only smooth muscle is compromised. So it is partial ptosis, not severe ptosis. And now you're telling that why it is partial ptosis because some muscle became unopposed. Yes. Tell me, any of you, which muscle became unopposed so that there was ptosis? Tell. Anybody? The question was, why there is partial ptosis? Which muscle became unopposed? Obviously, if one, yeah, orbicularis what? Oculi. Correct. Yes, Akshay and Alisha. Yes. Yes, Alisha. So that was the answer. You have to understand, orbicularis oculi is tightly shutting the eyelid. Orbicularis oculi is supplied by facial nerve. So facial nerve is orbicularis oculi, muscle of facial expression, shutting the eyelid. So that is what he wanted. Just imagine, like हिंदी में कहावत है जहां ना पहुंचे रवि वहां पहुंचे कवि. हिंदी में एक कहावत है जहां ना पहुंचे रवि वहां पहुंचे कवि. सर अंग्रेजी में बता दो. Poets, they can reach even those places where sun doesn't reach. Ravi is sun and Kavi is poet. Jahan na pahunche Ravi, wahan pahunche Kavi. Means the places where even sun cannot shine, the poets can reach. And this Zoom is asking, confirm your speaking language. It sounds you might have switched to different language. So, these examiners are like that. These examiners are like that. So these examiners, just imagine, like, what is it doing? He is asking orbicularis oculi has become unopposed and which is supplied by facial nerve. Just imagine. Anyway, so superior tarsal muscle not working, orbicularis oculi became more powerful, and that is why there was partial ptosis. Maybe we can assume like that. Metaphorically, yes, Deepak. So, as we are talking about the other thing, see, dilator pupil is not working. If dilator pupil is not working, you'll find that the patient is having meiosis. But why the patient is having meiosis? Patient is having meiosis because sphincter pupillae became more powerful. So sphincter pupillae became more powerful, which is supplied by third nerve. And there it was orbicularis oculi, which is supplied by facial nerve, became more powerful. So some muscles become unopposed, so they'll cause the other thing. So this patient in Horner syndrome has meiosis because we understand that if the dilator pupil is not working, which is supplied by T1 sympathetic, then the sphincter pupil is supplied by third nerve will become more powerful, there will be meiosis. Then third thing, there was a sunken eyeball. And why there was sunken eyeball? There was sunken eyeball because the orbitalis is not working. So sunken eyeball and orbitalis is not working. Here you don't have any muscle which pulls it back. So there is nothing like that, which muscle became unopposed. So why there was sunken eyeball? Enophthalmos. Enophthalmos is there because orbitalis is not working. So enophthalmos. And there is no contracting muscle that you have to find that which one became more powerful. There's nothing like that for orbitalis. Plus you saw there is anhidrosis. Why there is anhidrosis? Because no sweat, no sweating. And then you found that there was redness. Why there was redness and where was redness? Red conjunctiva and red skin. And also there was nasal congestion. There was nasal congestion. So there is red conjunctiva, red skin, and nasal congestion. Why? Because if sympathetic system is not working, then parasympathetic system causes vasodilation. So parasympathetic system leads to vasodilation, and that is why. So you are mentioning in this patient that first of all there is ptosis because superior tarsal muscle is not working. Then there is meiosis because dilator pupil is not working. Then there is sunken eyeball in ophthalmos because orbital is not working. Then you are telling there is no sweat, so anhidrosis. Then you are telling that sympathetic vasoconstriction not working, so parasympathetic vasodilation overworking. As parasympathetic vasodilation overworking, there will be redness. Redness is not only conjunctiva. Conjunctiva will become red and the skin become red. And nasal congestion. There is nasal congestion also. Yes. So all these are features, and I have not discussed it in detail. I have not discussed Horner syndrome in detail. And you must be wondering that how much detail could there be left now to discuss Horner syndrome in detail. But I have left something because I don't think they'll be going into those detail yet. If they start asking question, we'll start teaching. But at this moment, one thing which he'll definitely be focusing upon is why there'll be heterochromia iris, because that was favorite topic. So remember why there'll be heterochromia iris. There is a baby, mother is having difficult labor. Epistaxis we also feature. Epistaxis, dry nose, dry nose. Epistaxis means because there's vasodilation. That is why. Epistaxis mostly is because of dryness of the nose. So, which system is vasomotor rhinitis? Yeah, yes. Deepak, but it is not written in any textbook. It is not written in any textbook. I'll tell you why epistaxis can be there because this sympathetic system is for secretion also. It increases the secretions, not only sweating here. You know this vasomotor rhinitis. There's a condition called vasomotor rhinitis. The there can be uh, running nose. So thinking in those terms, I can think of means I'll have to study. Means I have not seen anybody telling in Horner syndrome there is epistaxis, but I can think of that. But I'll have to spend time on that. So we are not going there yet. Examiner, if he goes there, then we'll go. So why there'll be heterochromia iris? That is what we want to focus upon. See, there is a mother who is having difficult labor, and you are trying to bring the baby, trying to pull the baby out because baby will have cerebral ischemia. You don't want baby to have cerebral ischemia. You're trying to pull the baby out, and somehow baby has clump case palsy now. So you were pulling the baby out just to avoid brain ischemia because there was difficult labor, and you saved the baby, but there was clump case palsy. C8 T1 gone. Now, when C8 T1 gone, T1 gone. T1 gone means Horner syndrome. Remember, Horner syndrome is a feature of club case palsy. And this is congenital Horner syndrome because it was happening at birth only. So there's a situation here. We have mother with difficult labor. You are trying to save the baby from brain ischemia. So you pulled the baby out of birth canal somehow. And there was some injury. It was clump case palsy. Lower trunk has been pulled. So lower trunk of brachial plexus is pulled. So as the lower trunk of brachial plexus is pulled, it has root value C8 T1. So T1 gone. T1 gone means Horner syndrome, and it is congenital since birth. Now, understand this T1 sympathetic supply is important for deposition of melanin on iris. Deposition of melanin on iris. So, this T1 sympathetic system is important for deposition of melanin on iris, and it takes 2 years post birth. It takes 2 years for that post birth. Now, look at a baby who is born, newborn baby. Look at a newborn baby. You'll find all the newborn babies in this world will have blue iris, deep blue iris. Sometimes light can also be there, but they are blue. Indians, it is deep blue. So you are telling that when a baby is born anywhere in this world, maybe India or anywhere, the baby will have blue iris. Yes. Mostly it is deep blue, but it could be light blue also, but it is blue. Then how come it become black or dark brown? Like we have black or dark brown? Because T1 sympathetic system was depositing melanin on iris, and it takes 2 years. So that is how you understand congenital Horner syndrome can present with heterochromia iris. Say, for example, this baby was having right-sided Horner syndrome. And right-sided Horner syndrome, there will be blue iris. And what is the normal side? Normal side will be brown iris. This is called as the heterochromia iris. So understand, since we need T1 sympathetic pathway, which was compromised right at birth, since we need T1 sympathetic pathway, which was compromised right at birth, for the deposition of melanin on the iris, and it takes around 2 years post birth, this baby never had a chance to turn the blue iris into blue, will become green, will become brown. That is how it happens. So blue, if you mix, what is melanin? What is the color of melanin? Color of melanin is brown. So if color of melanin is brown, what will happen if you mix blue and brown? If you mix blue and brown, there will be green. And what if I continue mixing more brown? Then it will be brown, of course. So in the beginning, blue, it becomes green and then becomes brown. That is how the transition happens. Anyway, I think you got the point that this baby had right-sided concave palsy, right-sided Horner syndrome, right iris remained blue, but the normal iris became brown, so heterochromia iris. This question came around 10 years back, AIMS question, and it is about to come anytime because they have restarted the process. Okay, so can we look at this question now, which is page number 103? Yes, page number 103, they are simply asking ptosis in Horner syndrome. They start like this. First, they will test the water. They'll just ask some simple question and they'll see whether the student is answering or not. If they're answering, go deep, 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 and they go very deep sometimes. So, yes, it is the superior tarsal muscle, which is also a part of Miller muscle. It is superior tarsal muscle, part of Miller muscle. So, it was not working. That is why there is ptosis. Orbitalis, if it is affected, there will be enough thalamus. There will be enough thalamus, which is the sunken eyeball. And orbicularis oculi is anyway out. Sphincter pupillae means they were causing ptosis. This was causing ptosis. And sphincter pupillae was causing meiosis. It was causing meiosis. because dilator pupilla is not working. So as you can see, why there was ptosis, paralysis of which muscle? You say supradorsal muscle. And because supradorsal not working, so orbitalis became more powerful. It was causing the ptosis. And orbitalis, if it is not working, then enough thalmos. No counteracting muscle there. And sphincter pupillae became more powerful because dilator was not working and it led to meiosis. So like that, you just have some idea. Page number 103. Now we move further and we want to look at some details of larynx. Larynx has 9 cartilages, 3 paired, 3 unpaired. Let us look at them. So 3 paired and 3 unpaired, total 9 cartilages in larynx. Let us look at the larynx to count those. This is page number 105 now in the workbook. And let us look at the larynx from anterior view as well as posterior view. So anterior view and posterior view, because some cartilages cannot be seen from anterior view. You have to look from posterior view. So which cartilage can be seen from anterior view? You can see the largest of all, which is thyroid cartilage. And then you can also see the lid over larynx, which is the epiglottis. And you can also see one cartilage, which is ring-shaped cartilage. It is called cricoid. And because it is ring-shaped, it can be seen from anterior as well as from posterior. So this is a ring-shaped cartilage. Otherwise, the others are only anterolateral or like lid over larynx only. So you are talking about 3 midline cartilages now from the anterior view? Yes. Anterior view, 3 midline cartilage. And epiglottis is just like a lid over larynx. Epiglottis. And thyroid cartilage is the largest cartilage of larynx. Can be seen from the front view. It is anterolateral, covering the larynx. It is not posterior. But cricoid is like a ring. So it is anterior as well as posterior. Came as a question. So I can see cricoid from anterior as well as posterior. Yes. Okay, 3 unpaired you have discussed. Now talk about 3 paired. 3 paired you can see from posterior view. There is a pair of arytenoid cartilage, which is right and left. Over that you have C, the corniculate cartilage. This is corniculate cartilage. And over that you have another C, which is cuneiform cartilage. They are in pair. So 3 plus 3 is 6, which are paired one. This is arytenoid. So as we are telling that there are 3 unpaired which are seen here and 3 paired which are seen from the posterior view. They are a pair of arytenoid, pair of corniculate, and a pair of cuneiform. So 3 plus 3 is 6 plus 3 9. Total 9 cartilages. Yes, in the larynx, usually speaking, we have total 9 cartilages. Okay, so what about the muscles? Because questions come on muscles. Remember, there is one muscle which is on the anterior side connecting these 2 cartilages, hence the name. There's a muscle connecting these 2 cartilages, hence the name. What is the name? Cricothyroid muscle. Cricothyroid muscle, why this name? This muscle can be seen from the anterior view. This muscle can be seen from the anterior view. And it is called so because connecting cricoid with thyroid. So connecting cricoid with thyroid, that is why cricothyroid muscle. Yes. And remember, cricothyroid muscle is the only muscle which is supplied by the external laryngeal branch of superior laryngeal nerve of vagus, which is nerve of the fourth arch. Otherwise, the larynx muscle develop in sixth arch, and they should be supplied by the recurrent laryngeal nerve branch of vagus. So, as we are telling, all muscles of larynx, they are supplied by recurrent laryngeal nerve because they develop in sixth arch. I'll repeat the information. First of all, you tell this is a muscle named according to the cartilages it is connecting. Cricothyroid muscle on right side, left side, front view. So this is right side, that is left side. And cricothyroid muscle is the only muscle of larynx which is supplied by the external laryngeal nerve branch of superior laryngeal nerve branch of vagus. External laryngeal nerve branch of superior laryngeal nerve branch of vagus, because superior laryngeal nerve branch of vagus nerve is the nerve of fourth arch, and this muscle develop in fourth arch. So cricothyroid muscle develop in fourth arch. Yes. That is why it is supplied by muscle of fourth arch. Yes. So cricothyroid muscle is the only muscle of larynx which develop in fourth arch. Hence, it was supplied by superior laryngeal nerve branch of the fourth arch, nerve of fourth arch. Otherwise, all the larynx muscle develop in sixth arch, hence they are supplied by recurrent nerve. So, can we discuss some other muscles which are supplied by recurrent nerve, which will develop in the sixth arch? Yes. But before that, you tell cricothyroid muscle is a tensor of vocal cord. It is a tensor of vocal cord and it can increase the pitch of voice. It can increase the pitch of voice. And also mention here that females have high pitch voice. Females have high pitch voice. Now, if a male want to sing in female voice, he can train his cricothyroid muscle and he can sing in female voice. So, cricothyroid muscle is tensor of vocal cord. As you tense the vocal cord, you'll increase the pitch of the voice. And females, they have high pitch voice normally compared with male. And if a male want to sing in female voice, then you can train your cricothyroid muscle. And once you train your cricothyroid muscle, you can also speak or sing in female voice. Okay, what if a female want to sing in male voice? What if the female want to sing in male voice? Then you need to train relaxer of vocal cord. So can you tell me the relaxer of vocal cord? Yeah, you tell me. I am drawing the diagram and you tell me the name. I'll draw the diagram, you tell me the name. So by drawing the diagram, I can tell the name? Yes. Okay. So what is this? This is a muscle which goes anterior to posterior. Tell the name. A muscle going anterior to posterior. Tell the name. Thyroarytenoid muscle. Yes, very good, Akshay. Dream INI. Dream, okay. Dream INICET. Yes, very good. So this is thyroid. Yes. And what is thyroid doing? So thyroarytenoid, because coming from thyroid cartilage to arytenoid. Thyroid, remember, be careful about this. Thyroid, the posterior part of thyroid is a relaxer of vocal cord. So posterior part of thyroid muscle is a relaxer of vocal cord. Yes. So a female can use that and sing in male voice. Yes. Because you want to have a heavy voice. Yes, heavy voice or low pitch voice. Low pitch voice. Males normally will have low pitch compared with female. So you are telling that I could means a female could train posterior part of thyroid muscle because posterior part of this thyroid muscle is a relaxer of vocal cord. So I can use it and take the pitch of voice down, heavy voice. Yes. Okay. What about the anterior part? Anterior part is a tensor. Now, if you say the anterior part is a tensor, do we have two tensors now? Yes. So, are you trying to say that anterior part of thyroid is working with cricothyroid muscle? Yes, both are tensors of vocal cord. So, anterior part of thyroid work with cricothyroid muscle as a tensor of vocal cord. Yes, whereas posterior part of thyroid muscle is a relaxer of vocal cord. Yes. Okay. Now, this thyroid muscle has a medialmost part which is along the vocal cords. It is called vocalis. Vocalis. What is vocalis? The middlemost part of thyroid, which is running along the vocal cord, it is called vocalis. So you have to tell, I'll mention here, what is vocalis? Vocalis is medialmost part of thyroid muscle. So are you telling that vocalis posterior will be a relaxer of vocal cord? Yes, it is relaxer of vocal cord. Whereas if you are talking about the anterior, it will be tensor. So remember, vocalis is just the medial most part of thyroid muscle, and it is running along the vocal cord, running along vocal cords. So as we are mentioning, vocalis, what is vocalis? It is the medial most part of thyroid muscle running along the vocal cords. And if you talk about posterior part, it is a relaxer of vocal cord. Then vocalis anterior will be tensor. Yeah, vocalis anterior will be tensor because it will be here. Anterior are tensor, anterior part is tensor and posterior is. So questions are like, vocalis posterior, what is the action? You say vocalis posterior, it is relaxer of vocal cord as it is a part of thyroid muscle, like that. Okay. Now remember, most of the larynx muscles are adductors of vocal cord. Most of the larynx muscles are adductors of vocal cord, except one, which is also called as safety muscle of larynx, because it will open the vocal cord, and that is how we breathe. If you want to breathe, you have to open the vocal cord. So yes, as you are telling, I'll show you the diagram and you can name also. So as you see, this is the muscle. It can be seen from posterior side. And since it can be seen from posterior side, you say posterior connecting. So posterior cricoid muscle. Yes. Okay. PCAM. Yes. PCAM, posterior cricoid muscle. So as we can see it from posterior side, it is connecting cricoid with arytenoid. As we can see this muscle, uh, Deepak is asking vocalis and thyroid we used interchangeably in question. No, 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 cannot be. Vocalis is very small muscle and it is the middlemost part of thyroid. So normally they'll either ask thyroid or vocalis, though you can say that they are same, but cannot be interchangeably used because thyroid is a bulk of muscle and vocalis is very thin strip of muscle. Cannot use interchangeably. Cannot use interchangeably. So this muscle, which is seen from the posterior side, hence the name posterior, attaching cricoid with arytenoid. So cricoarytenoid. Posterior cricoid is the muscle which is a safety muscle of larynx. Why would you say it is safety muscle of larynx? It is the safety muscle of larynx because it'll open the vocal cord and you breathe. Open the vocal cord and you breathe. So why did this name come? Safety muscle. See, when you are giving general anesthesia, in general anesthesia, you use muscle relaxant. And when you use muscle relaxant, all the muscles are paralyzed, even the larynx muscle. Larynx is closed. How the patient breathes? How the patient breathes? When you give general anesthesia, you use muscle relaxants and larynx is closed. How the patient breathes? Because obviously, when you give muscle relaxant, all the skeletal muscle will relax. Even PCAM will relax. Safety is gone. It is the muscle which was keeping the safety. It was opening the vocal cord to breathe. Now, how the patient breathes? Actually, patient breathes from trachea. How the patient breathes from trachea? Because you have done endotracheal intubation. So, yes, because the patient is breathing from trachea, you have done endotracheal intubation. These patients do not breathe from larynx, they breathe from trachea. Now, there is a problem. A new house surgeon has come, excited, and asking the seniors, sir, madam, I want to do endotracheal intubation. And senior has a lot of patients. So, okay, do. And he has put the tube into esophagus only, not the trachea. So, it can happen that there's a new champion in the ward, in the OT. And since there are so many patients, so the champion is telling, Madam, let me do this endotracheal intubation. And since there are so many patients, the senior is telling, okay, do it. And he has put the tube into esophagus only. Though you can always check like it is in esophagus or in the trachea. And suddenly this patient is having breathing problem. And the senior looks back on the patient. Then the senior has to put the tube into trachea from outside. Tracheal, tracheostomy. You have to do tracheostomy now. If your tube is not inside the trachea, then you put the tube from outside the trachea. You have to do tracheostomy to save your patient. So just to tell you things that when you use general anesthesia, muscle relaxant, larynx is closed. But larynx is closed over your tube. You have put the tube, then the larynx is closed. And tube is actually in the trachea. The patient breathes from here. And if you have not put the tube into trachea, then you have to put it into trachea. Now cannot do it like this, so do it like this. Tracheostomy is needed. So that is why it is called safety muscle of larynx. If it is not helping you to open the vocal cord, you larynx is closed. You cannot breathe. Okay, with all that information which you have gathered here, you can come to this question, which is last year only, 2024. So somehow this question was asking singer, difficulty singing high pitch. With that only, you should get the idea. But still, laryngoscopic picture. Now, I don't know like which type of picture was there, but student told that something like this was there. You see, normally the cords are tensed. One of them is bowing. There's a bowing. And as there's a bowing, I'm considering that it is uh, not in tension. It is not in tension because this is a tensor of vocal cord, cricothyroid muscle. So if cricothyroid muscle is not working, which is a tensor of vocal cord, you may see some bowing of the vocal cord. This is bowing. This is normal vocal cord stretched, and there's a bowing of the vocal cord. So bowing means it is not in tension, means it is kind of vocal cords are like this. One of them is like this. It is not straight. It is like this. Bowing. There's a bowing. So anyway, without even looking at this, we could have got our answer here, and I hope like we are correct. So cricothyroid muscle, what happened exactly here? Actually, the surgeon was removing thyroid gland, and as a surgeon was removing the thyroid gland, he was ligating superior thyroid artery. And as the surgeon was ligating superior thyroid artery, he did not take care of the external laryngeal nerve, branch of superior laryngeal nerve, branch of vagus, and he has damaged it. So that is why this muscle was paralyzed. Uh, okay, now uh, Dream is asking, thyroid is also tensor in anterior part. Yes. External laryngeal lies close to ST. Yes. But then, Dream, if you take your answer as thyroid anterior part, it is supplied by recurrent nerve. And if it is recurrent nerve, then this is not the patient will present with. Patient will present with, if recurrent nerve is gone, all the larynx muscles are gone. He'll have difficulty speaking. Stridor will be there. There will be stridor. So, or there could be, so to answer your question, you are telling that thyroid muscle also is tensor in anterior part, yes. But thyroid is supplied by recurrent nerve. And if recurrent nerve was damaged, then all the larynx muscle on the same side, means whichever side you are having this problem, that larynx muscle will be compromised except for cricothyroid, and there will be stridor, not this specific complaint, high pitch voice. Right. So, yeah. So, as you remove the thyroid gland, you have to be careful. You were ligating the superior thyroid artery because you have to remove the thyroid gland, you have to cut the superior thyroid artery, but you have to be careful that should not damage the external laryngeal nerve which runs with the superior thyroid artery. So, what should I do? What you should do is, maybe you ligate the superior thyroid artery, or maybe you ligate the inferior thyroid artery. Always ligate as close as possible to the thyroid. That is the rule. So, rule is that whenever you are removing the thyroid gland, whether you ligate superior thyroid artery or you are ligating inferior thyroid artery, because you have to ligate and you have to cut them, that is how you will remove the thyroid gland. Always ligate them as close as possible to thyroid gland. Why? What will happen when I will ligate it close to the thyroid gland? That time, see, these two things are running together. The superior thyroid artery and external laryngeal nerve, they run together. But at one point, the superior thyroid artery goes supply thyroid, external laryngeal nerve supply cricothyroid muscle. So maybe these two things run together, superior thyroid artery and external laryngeal nerve. But at one point, they are one of them, superior thyroid artery will supply thyroid gland, other will go and supply cricothyroid muscle. So when they split, it is very much close to the thyroid gland. You ligate the artery here, then you will not damage the nerve. So that is what. But what about the inferior thyroid artery? Why would I ligate inferior thyroid artery? Yes, very good. Dream, you are telling perfectly fine. If you ligate the inferior thyroid artery away from the gland, then there'll be a problem. Because inferior thyroid artery has to supply a rectilineal nerve and also parathyroid gland. Then it will supply the thyroid gland. So inferior thyroid artery, you have to remember, it is a very inferior thyroid artery is very important artery. It supplies so many things actually. We'll discuss that. There is a topic on which we have to work. So inferior thyroid artery, of course, it supplies thyroid gland, but before it supplies thyroid gland, it also supplies rectilineal nerve and it also supplies parathyroid gland. Now you have to let the inferior thyroid artery give branches to rectilineal nerve, give branches to parathyroid gland, and when it was going to supply the thyroid gland, that is the time when you have to ligate it. Means as close as possible to the thyroid, because if you ligate it away from the thyroid, then you will put these structures into ischemia. There'll be ischemia of rectilineal nerve, there'll be ischemia of parathyroid gland. You don't want that. So that is why inferior thyroid artery should be ligated as close as possible to thyroid, because till that time it would have already given branches to rectilineal nerve and parathyroid gland, which you want to save. So that is how both the arteries should be ligated as close as possible to the gland. Here, the surgeon made a mistake, maybe, that he had damaged the external laryngeal nerve, branch of superior laryngeal nerve, which supply cricothyroid muscle. That is, cricothyroid is not working, and high pitch voice is compromised. Choice number C is the answer here. Then, as we talk about some details of ear, ear is a big topic, but question like who is forming the tragus of the ear and who is forming the ear lobule, which arch? Actually, the ear, external ear develop in two arches, first and second. And page number 108 now, page number 108. Page number 108 ear, you see first arch give three auricular hillocks and second arch also give three auricular hillocks. So 1, 2, 3 and 4, 5, 6. These three auricular hillocks come from first arch and the next three auricular hillocks come from second arch. These are 6 auricular hillocks. And they are going to contribute to the auricle. So as we are talking about the auricle development, questions come. First arch giving first 3 auricular hillocks, second arch giving next 3 auricular hillocks, total 6 auricular hillocks, they will form the auricle. In the auricle, sometimes they ask, like say this is the auricle, this is the ear lobule, and that is the opening external auditory meatus. And then this is the region of tragus. Here is tragus, this is tragus. So that is tragus, this is ear lobule, that is external auditory meatus, that is the helix. Deep down you will have antihelix. So if you are being very precise, grossly speaking, if you are talking about the first arch will contribute to tragus. First arch will contribute to tragus. And sixth arch, the second arch, the sixth one, contributes to lobule. Let me give a color differentiation that will be better. So first arch, let me use the red color. Second arch, let me use the blue color. And then I have to change this lobule and antihelix. So tragus come from first auricular hillock and lobule come from sixth. So let me just tell. First arch red color, second arch blue color. First arch, the first auricular hillock forms the tragus. First arch, first auricular hillock forms the tragus. And second arch, last auricular hillock, sixth, forms the lobule. So what all first arch form? First arch form the tragus and the helix, the red color. First arch forms the tragus and the helix, the red color. And second arch is blue color. It will form antihelix and lobule. The second arch shown in blue color, so it will form antihelix and the lobule. Lobule come from hillock number 6. Now this is controversial. This is controversial. Different books will give different theories, but I think you better follow what I taught you, though it is controversial. So number 1 give you tragus, and number 6 give you the lobule. So obviously that is second arch giving lobule and first arch giving the tragus, which is in front of the external auditory meatus. So just some idea. And anyway, this is page number 108 only. You have a table also. So page number 108, you have table. First three auricular hillocks forming tragus and helix crus. And second arch, the next three auricular hillocks, the antihelix and this lobule. So we don't go into much detail, but you can just remember this is the table which tells you some more detail if you wish to have. Page number 108. Now, our job is to talk about, before looking at the question, actually, we want to talk about, or we want to talk about the nerve supply, actually. Then we can talk about the question also. See, if somebody is having ear piercing in the lobule, there is a single nerve which will carry the pain, maybe lateral surface or maybe medial surface. If somebody having ear piercing here in the ear lobule, here, this point, maybe it is lateral as shown here, or maybe it is, this is lateral, medial. So maybe lateral or maybe medial, it is the same nerve. So that nerve is B. That nerve is B. Who is that nerve? It is called as greater auricular nerve, supply greater part of auricle. So as you need to see, this is lateral view, that is medial view of the ear, means lateral view and medial view, lateral and medial. The greater part of auricle is supplied by greater auricular nerve, that is marker B, laterally as well as medially. And if somebody is having ear piercing in lobule, maybe it is lateral pain or medial pain, that is being carried by same nerve, greater auricular nerve. But now somebody is having ear piercing here, up here, this upper 1/3 of the ear. That means now the ear piercing is here. At this point, let us use some other color. Maybe, okay, black is fine. This is patient number 2 now. So if the ear piercing is here now, then which nerves carry pain? That was number one. And this is number 2 now. So now the patient is having ear piercing in the upper 1/3 of the ear. Which nerve will carry the pain? In that case, laterally it is greater auricular nerve. This all area is greater auricular nerve, but upper 1/3, medially, occipital nerve, which is called lesser occipital nerve. Occipital bone, occipital nerve, but upper 1/3 on medially, this area. So it is called lesser occipital nerve. Now there are two nerves which will carry the pain, lesser occipital nerve, and of course there it is greater auricular nerve. And what if I have a puncture in my tragus? I'm a fan of somebody and I'm having this ear piercing in tragus also. Now what? If you are having ear piercing in tragus now, which is here, this is the tragus, then there is a nerve which supply this part and this part also. This anterior ear, A for A, you can remember A for A, anterior ear, auriculotemporal nerve, auriculotemporal nerve, auriculotemporal nerve. So you are telling that this is auriculotemporal nerve, which is a branch of mandibular trigeminal. Yes, mandibular trigeminal. That is the one which supply there. To have a better view, I'll show you a diagram. But if you were having a piercing in the tragus, it is A for A. Anterior is auriculotemporal nerve. And it supply not only the auricle, but also temporal region. Okay, then what is this green color? What is this green color? What about this green color? That is the auricular branch of vagus. That is the auricular branch of vagus. Okay. Hmm. Okay, so what about this external auditory meatus? Not only here, but also root of the ear. So medially root of ear, and otherwise this external auditory meatus, this green color. That is auricular branch of vagus. But be careful now. When you say this is the auricular branch of vagus, this is the auricular branch of vagus, there is one additional thing. Let me show you the diagram of ENT book only. So we have, it's the same diagram. So we already have the information. But you see one thing here now. First of all, greater part of auricle, maybe lateral or medial, is supplied by greater auricular nerve. And if somebody asks dermatome, C2 is a better answer. C2 is a better answer. So greater auricular nerve supply greater part of auricle. Maybe it is the lateral auricle, or maybe it is the medial auricle. If you talk about ear lobule, maybe lateral or medial, it is supplied by greater auricular nerve. But if you go to the medial side and upper one third of ear, then it is lesser occipital nerve. Only medial, not lateral. Laterally, it is great auricle only. And if you are talking about the tragus, then anterior, A for A, it is auriculotemporal nerve. My point is, why have they written for external auditory meatus and root of the auricle, the facial nerve? What is facial nerve doing here? Why did they mention facial nerve? Because it is basically auricular branch of vagus. It is called auricular branch of vagus. So what is facial nerve doing here? So this you have to understand. Facial nerve has a role. So what is the role of facial nerve? You see, vagus nerve was going down. It has to supply head, neck, and thorax and abdomen. So vagus nerve was going down. It has to supply head, neck, thorax, and abdomen. But it also wanted to supply the ear. It also wanted to supply the ear. So it wanted to send some axons to ear, but it itself doesn't go there. So it has some axons and it wanted these axons to reach the ear, but itself doesn't go there. Vagus nerve doesn't go to ear. It is in the head neck region, then it is in the thorax region, abdomen region. It is not going to ear. So how will it send these axons to the ear? It was asking the facial nerve. It was asking the facial nerve. Facial nerve, are you going there? Facial nerve says, yeah, I'm going there because I have to supply muscles of facial expression. And to reach the muscles of facial expression, I will be passing there. So it is telling, could you please take my axons also? Let me show in some other color. So could you please take my axons also to the ear? And facial nerve obliges. This is called as hitchhiking. This is called as hitchhiking. So basically, the facial nerve axons were hitchhiking. This vagus nerve axons, they were hitchhiking the facial nerve to reach their destination. That is what you have to understand. So what is the clinical relevance of this? See, vagus was going to supply head, neck, thorax, and abdomen. It never goes to the ear and supply. It will just send some axons. But those axons, how do they reach the ear? So Vegas is asking facial nerve, are you going there? Facial nerve say, yeah, I'm going there because I have to supply muscle of facial expression. What is the job? Vegas tells the facial, take few axons of mine and supply the ear. And it will oblige. So axons of facial nerve, they are hitchhiking the facial nerve to reach the ear. So what is the problem? Problem is, there was injury of facial nerve here. There was injury of facial nerve and there is sensory loss in the external ear area. And you are thinking, I have damaged facial nerve, why there is sensory loss? I have damaged the facial nerve, why there is sensory loss? You are expecting that there should be no sensory loss because this is vagus nerve supply. Why there is sensory loss? Because when you have damaged the facial nerve, you have also damaged the auricular branch of vagus, axons. That is why. And that is why it is written here that the area is supplied by, of course, the first answer will always be vagus. But if vagus is not given, your second answer is facial nerve. So you have to understand that why facial nerve is given here, because axons of vagus, they were hitchhiking facial nerve. And if you damage the facial nerve, those axons are also gone. That is what. So that you have to understand. So here, as you can see, that of course, somebody asking about this, you will always tell that it is the vagus nerve which is supplying, auricular branch of vagus which is supplying. But if it is missing, then you can say facial nerve carrying those axons is supplying. And axons of vagus, they hitchhike the facial nerve. Now, old age, olden times, Romans will put some cold water into the external auditory canal, and that will be irritating the vagus nerve. As vagus nerve get irritated, there'll be more of gastric secretion, and they will do this before going to a big feast. So, what the Romans were doing? The Romans, in earlier times, they'll put some cold water in the external auditory meatus, and which will irritate the vagus nerve, auricular branch of vagus. And then, as you put the cold water and it is irritating the auricular branch of vagus, it is going to CNS. And CNS is unable to decipher that where is the problem. So, as the nerve is irritated, it will start working in the area also. Means more of gastric secretion, more of enzymes, and you can have more of food. That is what they used to do. Recent time, you do syringing, and in syringing, you are having vasovagal syncope. So why you are having vasovagal syncope? Because when you are syringing, maybe you irritated the vagus nerve. That was the information going to the CNS. Vagus nerve got irritated. It is a parasympathetic system, causes bradycardia on the heart and syncope. So as you should be careful while syringing, because ear syringing, because you can irritate this vagus nerve. As it is irritated, it will be telling the CNS, and the vagus itself will be activated, and it can cause bradycardia, parasympathetic bradycardia, and syncope. Sometimes you are doing the syringing and patient is coughing. So what is that? Because as you irritate the vagus nerve, the brain is thinking that something is wrong at the vocal cord level, because vocal cord level again vagus supplies. So cough will come. So all these things are connected. And this definitely is vagus nerve, which is getting irritated, though it is carried by facial nerve. And it can result in vasovagal syncope, it can result in cough, and other things also. Increase gastric secretions, all that can happen. So are you trying to say that it also supplies external auditory meatus? Yes. Not only the beginning of this, it also supplies the canal. So which part of canal? Anterior and inferior. That is anterior and floor of the canal. So vagus nerve supplies anterior-inferior in the external ear canal. And inferior means it is floor, so it can be irritated there. So remember, anterior and inferior aspect of the ear canal, that is where vagus nerve supplies. Anterior wall and the floor. That you remember. Not only auricle, it is supplying deeper also. Okay. Yeah, Arnold's nerve. That is the other name. Auricular branch of vagus is also called Arnold's nerve. That comes as a question sometime. Arnold's nerve. All of these are questions only. Right. Now, once you are done, you can look at this question. I think there shouldn't be any problem in matching, because we already have this page number 109. We already have taken care of the details. So I will show you the marked area, marked answer. This is the marking. B is the answer. Okay, so that was some detail about the ear. Is the seventh nerve post and superior of seventh nerve, posterior and superior, facial nerve. Mm, which is the other nerve here? Glossopharyngeal nerve. Glossopharyngeal nerve. Facial nerve. Which is the deeper nerve? Just have to remember. Auriculotemporal nerve. I think auriculotemporal nerve should be there. Sir, is there any particular name of facial and vagus nerve complex? No, it is not any special name. It is just you say that it is facial nerve carrying the axons of vagus, or you can say vagus axons are hitchhiking the facial nerve branches. Let me just, I'm unable to recall posterior superior of external ear canal. Go deeper. What about tympanic membrane? What about the middle ear cavity? Is it? No, it cannot be glossopharyngeal. Glossopharyngeal nerves supply the middle ear cavity, eustachian tube, and mastoid ear cells. So glossopharyngeal nerve is supplying middle ear cavity, eustachian tube, and external this mastoid ear cells. Facial nerve doesn't supply the auricle. Does it supply the auricle? Let me confirm. Just give me a second. Your superior. No. Anterior and superior. Okay. Mm, facial nervous intermedius. Right. See, that is what we made a mistake, uh, and it is easy to correct. I think we made a mistake, and it is easy to correct. See here, which nerve is anterior? A for A, auriculotemporal nerve. So anterior wall, and I told you anterior and inferior supplied by the vagus nerve, but it is posterior and inferior. It is posterior and inferior. So in the floor is of course vagus nerve. That is what is irritated when we syringe. So it is not anterior and inferior. It is posterior and inferior, the vagus nerve. Then who is supplying anterior and the roof? Anterior and the roof, because there are four walls, isn't it? Canal means four walls: roof and anterior, and then floor and posterior. So you can say if it is posterior and the floor, it is, see, the look at this. Posterior and inferior, which nerve is there? The auricular branch of vagus. And anterior and roof is which nerve? Auriculotemporal nerve. If we draw it like this, say this is the canal, this area, floor and posterior, that is the auricular branch of vagus, auricular branch of vagus. And if we are talking about the anterior and the roof, as the diagram is showing, auriculotemporal nerve. Facial nerve does not supply at all, actually. Facial nerve does not supply. So this is anterior wall. That is the roof. And this is the floor and the posterior wall. As the diagram is also making it evident. So I hope you got the point. See, the floor and posterior wall is by vagus in the canal, and anterior and roof is auriculotemporal nerve. As per the diagram also means they are not only supplying the exterior, they are also going interior. Facial nerve does not have any sensation to be carried by the canal. As far as my knowledge, maybe I'll have to look into the details. So, is there any particular name of facial nerve? Okay, yeah. Facial nerve supply posterior and superior. Posterior and superior. So just correct the thing, the information which we collected earlier, that auriculotemporal nerve is A for A, so it will supply anterior wall and roof, whereas the vagus is at the floor. When you syringe, the floor is irritated, so vagus is irritated. So it is posterior and the inferior, means floor. The correction. Posterior superior EAC by sensory division of facial nerve. This work. That's what I was thinking. Is the facial nerve actually supplying the canal or not? Posterior superior EAC sensory division of facial nerve. See, that is Akshay. This is perfectly right. As you are telling, posterior superior external auditory canal is sensory division of facial nerve, Disberg nerve. Yes, but then it is carrying the axons of vagus. It is carrying the axons of vagus nerve. If I have to choose between the answers, my first answer will be vagus nerve. That is what I am telling you. That is what I was trying to tell you. It's correct that posterior superior, you are telling. I think I will have to work upon this topic then. Why are you telling posterior superior? It should be posterior inferior. Let me look at a diagram if available. These diagrams are also so complicated. But anyway, for the time being, just remember what I told you. Yeah, it is better to leave. For the time being, according to my knowledge, means the knowledge which I have, and what we see here in front of our eyes also, the floor and posterior wall is supplied by the vagus nerve and carried by the facial nerve. Facial nerve does not supply, actually. For me, it does not supply here at all. It is just mentioned because it carries the branches of vagus. And if you say anterior and roof, then it is the anterior means A for A, auriculotemporal nerve, and roof is also taken care of by the auriculotemporal. Till the time, I'll go back, do some research. Tomorrow, I'll tell you what exactly the scenario is. Because I think ENT people also are definitely teaching all this. But there is some controversy, definitely. Let us just leave the topic for the time being. I'll go to my place and do some research. Then I'll find out the diagram of Gray's anatomy. Let us see. Okay, so esophagus. Page number 111. Esophagus, as we understand, is a part of the gut tube, but then it is not in the abdomen. So a question comes, like gut tube, it will have four layers, which is normally we say mucosa, submucosa, muscular externa, and serosa. But then esophagus, one of that is actually missing. So as we talk about this page number 111, you'll have esophagus, gut tube will have four layers, and like mucosa, submucosa, muscular externa, serosa. So which layer is missing from the esophagus? Esophagus is not in the abdomen. Most of it is 25 centimeter long. So most of it is actually in the head neck region, thorax region. So it doesn't have the peritoneal serosa. Yes, correct. Correct, Deepak and Dream. So as you can see, let us draw the diagram. And it is quite a long tube. And we understand that it is only this lower part. Once it has passed through the diaphragm, once it has passed through diaphragm and then it becomes continuous with the stomach. This is the stomach. That part, maybe here you may have serosa. So serosa is there, but only in the lower part. In the upper part, doesn't have serosa. It is called connective tissue adventitia. So when we are talking about esophagus, this is the esophagus. Esophagus, some questions keep coming. So esophagus is about 25 centimeter long. All of these are questions. So when you talk about the esophagus, esophagus is about 25 centimeter long, and it is a part of gut tube, so it'll have all the layers of gut tube, but only lower part of the esophagus, when it is continuous with the stomach, that part will have peritoneal serosa, because now you got peritoneum here. Otherwise, if you look at the proximal part, most of the length, it doesn't have the serosa, it is connected to adventitia. Number two, if you look at the esophagus, it is one special feature that it has glands in submucosa. And glands in submucosa is a rarity. You don't find them. Only two places. One is this, other is this proximal duodenum. In the proximal duodenum, you have Brunner's gland, and those Brunner's gland are again submucosa gland. Otherwise, glands are in the mucosa, not in the submucosa. I'll repeat. This is number two. So, esophagus is special in some categories. Like number one, it doesn't have the peritoneal serosa except for the lower end. Most of it is lined by connective tissue adventitia. Number two, esophagus is part of gut tube which has glands in the submucosa. Normally, glands should be in the mucosa, not in submucosa. But esophagus is the place where you have glands in submucosa. And there is one more place where you have glands in submucosa, which is a rarity to see. It is the Brunner's gland in the submucosa of proximal duodenum. Only proximal duodenum, not the distal. So only in the proximal duodenum, in the submucosa, you have glands. Otherwise, glands should be in the mucosa. Number three, esophagus is having three parts: upper one third, middle one third, lower one third. In the upper one third, it will have skeletal muscles in the muscular externa. And in the middle one third, it will be skeletal plus smooth muscles in the muscular externa. And the lower one third, it will have only smooth muscles in the muscular externa. So that I think you know already, but middle is mixed. So in the middle, it is mixed. Otherwise, in the upper one third, it is only skeletal muscle. So there's a transition basically. A transition is happening. Upper one third of esophagus muscular externa has only skeletal muscles. Middle one third is mixed, skeletal plus smooth. And in the lower one third, this should be lower one third. So as you look at the lower one third, you'll find that it is mixture. And that mix is basically in the lower one third, it is only smooth muscle, means middle is mixed, and lower one third is only smooth muscles. Now, the other questions they are asking on the esophagus is, where does it begin? Where does it begin? So, where the pharynx will end, esophagus will begin. Larynx, pharynx, they end. Trachea, esophagus, they begin. So, where the larynx, pharynx will end, so that the trachea, esophagus begins. It is the lower border of C6 vertebra posteriorly, lower border of C6 vertebra, or you can say lower border of cricoid cartilage anteriorly, because after cricoid it is trachea. So lower border of cricoid anteriorly, cricoid cartilage anteriorly, larynx end, the trachea begins. Similarly, pharynx ends and esophagus begins. They begin at the same level. So if we are talking about the beginning of esophagus, it is lower border of C6 vertebra, or you can say lower border of cricoid cartilage. That is begins at. So these are something. The other thing they are asking about esophagus is about the constrictions. Now, as you talk about the physiological constrictions, basically, as you talk about the constrictions, there is a controversy. And what is the controversy? Let me tell you. If you look at the narrowing in the esophagus, means physiological narrowing. This is physiological, normal means. Then you'll find that narrowings of esophagus. Radiology people will say there are 5 narrowings. ENT and surgery people, they say there are 3 narrowings. And anatomy people say there are 4 narrowings. So whom should we follow? Because in the exam, they don't say that this question is given by anatomy department or radiology department, or they don't mention that answer from Grey's Anatomy, answer from ENT Dhingra, answer from Sutton Radiology. They don't say that. So how do I decide that question came from radiology people or surgery people, ENT people, or anatomy people? That is a problem. To deal with that, you have to practice a lot of questions and find some way that whatever question they ask, we reach the answer. Whatever question they're asking, we should be able to reach the answer. And that can be done only if you have read anatomy books, you have read radiology books, if you have read ENT and surgery books, then only you will be able to handle that. And that's what I do. So let us talk about these narrowings, and then we can try to decide that what is the best possible answer. Here, you start again telling that this is the esophagus, and it is about 25 centimeter long. And we are putting a Riles tube. That Riles tube has some markings. We calculate those markings from upper incision. So we want to know the length of the Riles tube from the upper incision as you are putting it into the, it is a gastric tube, so nasogastric tube. So you calculate from the upper incision. It is not nasogastric, means you can put through oral cavity also, orogastric tube into the, for maybe for feeding purpose or some other purpose. So as we are talking about the vertebra, what is this here? This is C6 vertebra lower border. So C6 vertebra lower border, it will begin. And then it is the T10 vertebra. It will be passing through diaphragm. At T10, it will pass the diaphragm. T11, it will become continuous with the stomach. So these are some of the levels which we should know. Again, I'll tell. This is about the esophagus. And esophagus, we know that we can put Riles tube, which has some marking, through the esophagus into the stomach. And as you are calculating the marking from the upper incision, there are some centimeters which you have to tell. The esophagus begins at lower border of C6 vertebra because pharynx ends and esophagus begins. Right at the beginning with the, here you will have a sphincter also, which is called cricopharyngeal sphincter. Because of cricopharyngeal sphincter, this is the narrowest lumen of esophagus. So narrowest lumen of esophagus is just at the beginning because of a sphincter, which is called cricopharyngeal sphincter, which is at the C6 vertebra lower border. Then as the esophagus passes through the right crest of diaphragm, it has to pass through right crest of diaphragm to enter the abdomen. It is T10 vertebra, and it is at T11 vertebra that it will be continuous with the stomach. So some part of esophagus is definitely below diaphragm in the abdomen region. Diaphragm means it is thoraco-abdominal diaphragm. So most of the esophagus is in the thorax, but partly it is in the abdomen. As it pierces the thoraco-abdominal diaphragm, it will reach the abdomen, and that is the part where you have peritoneal serosa also. But there is one more marking here in the middle. What is that marking? We have to talk about. And if you are calculating the Riles tube, you can tell as you enter the beginning of the esophagus, where you have narrowest lumen from the upper incision, it is 15 centimeter. So that is the 15 centimeter from upper incision. And as you pass through diaphragm, it is 40 centimeter. So that is 40 centimeter. So as you are talking about the Riles tube has a marking calculated from the upper incision. It is 15 centimeter and tells that now you are about to enter the esophagus. Be careful because this is the narrowest lumen of esophagus. Don't poke your Riles tube here and there and damage the mucosa. That is the warning sign. On the Riles tube, you have 15 centimeter marking to tell you that now you are entering the esophagus. So calculated from upper incision, this is 15 centimeter. And calculated from upper incision, it is 40 centimeter that it is piercing the diaphragm. And after some time, it will become continuous with the stomach. But what about the narrowings which are in the middle? So you'll see there are two more narrowings as per Gray's anatomy. So what are these two more narrowing as per Gray's anatomy we want to discuss, because whenever there is controversy, it is advisable to follow Gray's anatomy. if possible. So what are these narrowing due to? This is esophagus. It is almost running on vertebra. First, you have the vertebra. On that, you have esophagus. In front of esophagus, you have a lot of structures which can compress the esophagus posteriorly. So, what are these structures which can compress the esophagus posteriorly? You are looking from the front view. Let us detach those structures and keep them on one side. Let us keep the esophagus there and detach these structures and keep them on one side. Like you tell, this is the central tendon of diaphragm, and on the central tendon of diaphragm, we have the heart, and this heart has four chambers, and the heart is giving us the vessel which is from the left ventricle. So this is the ascending aorta, and as the ascending aorta comes, it will be forming the arch of aorta, and then it will form descending aorta. So this is the arch of aorta basically, which is compressing esophagus posteriorly. So here we are telling that we have removed all these structures from in front of the esophagus to maintain some clarity. They are all in front, but we have removed them, kept here. So on the central tendon of diaphragm, you have the heart with four chambers, and the left ventricle sends this vessel, which is ascending aorta, and this ascending aorta then becomes the arch of aorta, then descending thoracic aorta, and it was the arch of aorta which was compressing the esophagus. So where is it? According to Gray's Anatomy, it is 23 centimeter. According to Gray's Anatomy, it is 23 centimeter. So we are mentioning that we are having this central tendon of diaphragm on which the four chambers of heart and left ventricle sending ascending aorta, which is then becoming the arch of aorta, becoming descending thoracic aorta. But it is the arch of aorta which was compressing esophagus posteriorly, and according to Gray's Anatomy, it is 23 centimeter calculated from upper incision. I have seen short surgery telling 25 centimeter. So I have no problem making it 25 also. It is 23 to 25, no problem. So according to Gray's, it is 23. According to Sebastian surgery, it is 25. But no problem. You can say 23 to 25, no problem. Now, what is this narrowing due to? That you see, draw that this is the trachea here. Trachea to the right side of midline. And it is bifurcating into bronchus. And it was the left principal bronchus, which is compressing here. And it is 28 centimeter from upper incision. So, first of all, you are telling that this is the trachea. Yes. And trachea is to the right side of midline. Yeah. Trachea is to the right side of midline. Esophagus slightly to the left side of midline. So since the trachea is to the right side of midline and esophagus slightly to the left side of midline, it is actually the left principal bronchus which compresses the esophagus. So as we understand, trachea in the midline giving right principal bronchus, left principal bronchus. And since esophagus is to the left side and trachea to the right side, it is left principal bronchus behind which esophagus is compressed. So as the left principal bronchus, this is trachea dividing into bronchus, this left principal bronchus compresses esophagus posterior, it is 28 centimeter. Now, so I have told you four things. Number one, 15 centimeter, which is here. Then I told 23 to 25 centimeter, which is here. 28 centimeter, which is here. And 40 centimeter, which is here. Now, radiology people, they are telling that this left atrium is also producing a narrowing here. This is radiology people. Now, if radiology people are telling that it is left atrium, which is producing an compression or narrowing in the esophagus, this is not acceptable until there was some left atrial hypertrophy. If there's a case of left atrial hypertrophy, okay, agreed, there can be compression. Normally, it is not there. Maybe radiology people are telling, but we will not agree to them. That is the point. I'll agree to them only if there was left atrial hypertrophy. Maybe then there was a compression. Otherwise, normally it is not, because it is not there in Gray's Anatomy. So radiology people say 5 normally. Yes, they add this one, which should be added only if there was left atrial hypertrophy. One question came, when you are doing transesophageal echocardiography, which chamber do you see first? So question was, when you do transesophageal echocardiography, yes, you already told. So transesophageal echocardiography means you are putting a tube into trachea, into esophagus, and you are searching for the chambers of the heart. You can see all the 4 chambers, obviously. If you do transesophageal echocardiography, you can see all the 4 chambers. But what is the first chamber you see? Is left atrium only. So left atrium is in close approximation to the esophagus. And if it is hypertrophied, it will compress the esophagus. There can be dysphagia. It can result in dysphagia, left atrial hypertrophy. So transesophageal echocardiography, you see the first chamber is left atrium. That is again a question. So what about the ENT people? What are they doing? Let me talk about ENT people also. But this is the diagram you will see on page number 111. So as you look at this diagram, which is on page number 111, here you are looking from front view. This is the side view, sagittal. And in sagittal view only, you have taken some fluoroscopic radiograph. Fluoroscopic radiograph. So front view, this is sagittal view, and this is fluoroscopic radiograph, and this is anterior, and that is posterior. This is anterior, that is posterior. So what is this narrowing? First narrowing due to? What is this second narrowing due to? What is this third narrowing due to? What is this fourth narrowing due to? What is this fifth narrowing due to? That is the point. So you can see that there are radiology people say 5. So first, second, third, fourth, and fifth. Obviously, the first is like as it is beginning. So there will be cricopharyngeal sphincter, cricopharyngeal sphincter. So right at the beginning, cricopharyngeal sphincter, cricopharyngeal sphincter, cricopharyngeal sphincter, narrowing, narrowest limit. Okay, what is the second one? Second one is when you are having this arch of aorta. So when the arch of aorta is compressing, that is the second one. The second one is arch of aorta. So as the arch of aorta compressing, so this is esophagus here, posteriorly. That is esophagus. So arch of aorta is compressing esophagus. That is number 2. Then you have left principal bronchus, left principal bronchus. So as you talk about left principal bronchus, this is number 3. Then radiology people say there is left atrium. It is compressing here. Left atrium, it is compressing here. And then when the esophagus passes through diaphragm, when esophagus passes through diaphragm, that is the last narrowing here. This one, number 5th. So this is radiology people telling 5 narrowing, and we are telling this is not happening. This is happening only if you had a case of left atrial hypertrophy. Otherwise, we don't have this normally. So it is better to remember like this, that maybe there is a narrowing, but we don't consider it. We will consider only if there was left atrial hypertrophy, this left atrium compressing, then it is there, otherwise it's not there. So this is the Gray's anatomy. Follow Gray's anatomy strictly. What is Gray's anatomy telling? It is telling site of constriction, vertebral level, and distance from upper incision. So cricopharyngeal sphincter, C6 vertebra, 15 centimeter of upper incision. Aortic arch, T4 vertebra, 23 to 25 centimeter. I can make that because Western surgery is telling. Left principal bronchus, T6 vertebra, 28 centimeter. And esophageal hiatus, T10 vertebra, 40 centimeter. We already have discussed everything. Just what is added here is the T4 and T6 vertebra. So T4, T6 vertebra added, you just remember them. Now, as you have this information, what about the ENT people? ENT people, what they do is they tell that there is aortobronchial narrowing, bronchoaortic or aortobronchial narrowing, and they consider it as 25 centimeter from upper incision. So that is what they do. ENT Dhingra, you will see this. In the ENT Dhingra, it is there. Bailey Love or some surgery book is telling this Bailey Love, I think. Aortobronchial narrowing means they are mixing these two. How can you mix this one and this one? They are mixing 2 and 3. They're telling this is one narrowing only. So how can you do that? This is wrong. But anyway, aortobronchial, they tell this is 25 centimeter. Means aortic arch and left principal bronchus are at the same level. Are they at the same level? T4, T6 vertebra, such a huge difference, and they're telling at the same level. So anyway, we cannot follow ENT and surgery people, but that is not the way. The way is you have to look for the most appropriate answer. Just look for most appropriate answer, and you will not know the most appropriate answer until you have practiced some 20 questions on that topic. So there are some 20 questions in last 15 years. In those 20 questions, each answer is different. And why each answer is different? Because three departments telling three answers. Actually, four departments: surgery, radiology, ENT, anatomy. So, and the examiner never mentions that I have asked this question from BD here. Distance. Now, see, look at this fellow, Deepak. Deepak is asking, what is the distance of left atrium? Tell us. So I'm digging and he is digging more. That okay, if it is left atrium, tell the distance. Let us guess. It is not guess actually. It is given by a book. What is that? This is some book by, it is some laparoscopic surgery book is there. I am not getting the name. 30 centimeter it is. It is written there, 30 centimeter, 30. Left atrium at 30 centimeter. But don't go this deep. If we go this deep, then we'll be in a lot of trouble. So how deep should we go? Balliol anatomy. No, Balliol anatomy doesn't mention about left atrium as a normal physiological narrowing. No, it is not there. It is in certain radiology, actually. Anyway, so my advice, always try to follow this table. This is the Gray's anatomy. I can do maximum is 23. I can agree 25 because substance surgery, I'm agreeing to that. And even I'm agreeing to this 25 centimeter if that was the last resort option. Otherwise, I will not agree to this. Then how T4, T6, that is such a difference, and you are merging them together. How can you merge them together? But they have done that. So what is the problem? Problem is such questions. Such questions. Page number 111. What is your answer? What is your answer? Try to follow Gray's anatomy as much as possible, but you can manipulate your answers. So while performing upper GI endoscopy, a perforation was 25 centimeter from upper incision. So I told you 23, it is arch of aorta according to the Gray's. 25 centimeter, it is arch of aorta according to Sebastian. So Gray's and Sebastian surgery. So yes, yes. So we will say arch of aorta because if you are following now, if you are following Bailey and Love, or if you are following ENT Dhingra, then you will be in soup. You know what is soup? You are in soup. Why? Because then you have double answer. What will you do? Because if you follow Bailey Love and ENT Dhingra, then you are in soup. Because they are telling 25 centimeter from incisor is two answers, C as well as D. So that is the problem. Mix up. So in such a case, always try to follow Gray's anatomy, but you cannot follow Gray's anatomy because it is 23. So what to do? There is no, it is 25. You cannot follow Gray's anatomy. That is why you are taking support of Sebastian. So there are some questions which are like this, though they are not very frequent, but Some questions are like that. He should have mentioned here answer from Western surgery. That's all. Or maybe this is a surgeon who has asked this question, but he doesn't know that ENT people do something, and his fellow only, Billy Love, does something else. So, my advice, just follow this table, which is I have slightly modified, and it'll lead to all the possible deviations or any questions, maybe ENT people asking or whoever asking. Just remember this also, which is an aberration that some of the authors they say bronchial narrowing is 25 centimeters. Remember this also, because sometime if the ENT people are asking, maybe they'll ask from here. So just remember this also. This is also important. Maybe it is an aberration, but remember the aberration. You should have complete picture, basically. Now, we want to talk about some arteries here and external carotid artery branches. Then we can talk about subclavian artery branches also. So external carotid artery, as you follow, it will give 8 branches. And these 8 branches, 3 are anterior. There will be 2 posterior. And there are 2 terminal and 1 medial. So let us look at those branches. Total 8 branches. We are mentioning this is common carotid artery, bifurcating into 2, which is internal carotid artery and external carotid artery. And external carotid artery is giving us 8 branches. So as we are looking at common carotid artery, bifurcating into internal and external carotid artery, external carotid artery giving 8 branches. In the 8 branches, you can mention 3 anterior branches, and then you can tell there are 2 posterior branches, and then you can tell there are 2 terminal branches. So let me use some other color. 2 terminal branches. So what? And there is 1 medial branch, which I will show. So as we are looking from the side view, this is side view, means this is posterior and that is anterior. This is anterior. So we are looking from side view. As you're looking from side view, you're telling this is anterior and that is posterior. That is why these are 3 anterior branches, 2 posterior branches, and 2 terminal branches. So what are the 3 anterior branches then? Given by external carotid artery. The very first branch is going to supply the thyroid gland here. So it is called superior thyroid artery. The other one supply the tongue. So it is called as lingual artery. And the third one, anterior one, supply the face. So it is called as facial artery. So as you can see, the 3 anterior branches from the external carotid artery. The 3 anterior branches from the external carotid artery, one is supplying the thyroid gland, so superior thyroid artery. One is supplying the tongue, so lingual artery. One is supplying the face, so facial artery. 3 anterior branches. What about the 2 posterior branches? 2 posterior branches, one is going to occipital bone, so occipital artery. And the other one is going behind the ear, so posterior auricular artery. So as we talk about the posterior branches, you'll see, let us do one thing. Okay, doesn't matter. So as you are telling, the 2 posterior branches, one is going to occipital bone posteriorly, so it is occipital artery. One going behind the ear, hence posterior auricular artery, and then 2 terminal branches. In the 2 terminal branches, one of that is going to supply maxilla bone. As it is supplying maxilla bone, so it is called as maxillary artery. And the other one supplying temporal bone, so it is called temporal artery. Temporal bone, temporal artery, full name, superficial temporal artery. Superficial temporal artery. So 7 we have seen. 3 anterior, 2 posterior, and 2 terminal. Terminal are called according to the region they supply. If you are supplying the region of maxilla bone, maxillary artery. If you are supplying the temporal bone region, temporal artery, full name, so official temporal artery. And there is one medial branch, and medial branch you cannot show, but you can just mention that this is second branch, and it is going medial. It is called ascending pharyngeal artery. So ascending pharyngeal artery. It is ascending and supplying the pharynx. It is second branch, usually. So who is the first branch then? It is superior third artery. So superior third artery is the first branch, ascending pharyngeal artery is second branch. But be careful, ascending pharyngeal artery has variable origin, and it may sometime become first branch. It may sometime become third branch also. Question comes, which is the first branch of external carotid artery? Always answer, first branch of external carotid artery is superior third artery. Though this ascending pharyngeal artery, which we are showing as second branch, may become first sometime. It may become third also sometime, but it is sometime. It is aberration. So whenever a question comes, first branch of external carotid, it is always answered as superior third artery. This is, you can say, second branch. Now, this ascending pharyngeal artery supply the pharynx. The name is telling it will supply pharynx, but not only it supply pharynx. It is supplying the palatine tonsil and eustachian tube also. So it supplies three things. What are the three things it is supplying? The ascending pharyngeal artery. The name is ascending pharyngeal artery. It is a medial branch. First of all, it is a medial branch. Other branches are either anterior, posterior, or superior, but this is medial branch. So ascending pharyngeal artery, the only medial branch is supplying the pharynx. Of course, the name is pharyngeal artery, it will supply pharynx. But along with that, it is also supplying palatine tonsil and eustachian tube. Palatine tonsil and eustachian tube. Okay, so what about the other branches to palatine tonsil? What about the other branches to palatine tonsil? So to discuss that, you can show tonsil here. Tell this is the tonsil. T is tonsil. And remember, mostly it is supplied by facial artery branches. Show it above the facial artery. So T for tonsil, and tonsil major supply by facial artery. Now, as you show this tonsil and major artery is facial artery, there is additional supply from the ascending pharyngeal artery. Yes. But then that is quite after some time. Before that, you tell other names also. So what are the other names? This facial artery give a branch which is called as ascending pharyngeal artery, and that ascending palatine artery, and ascending palatine artery also supply the tonsil. Let me show in a dotted line. So what is this APA? Ascending palatine artery. And who is giving this ascending palatine artery? Ascending palatine artery is a branch of the facial artery. Okay, so you are telling that facial artery give the supply to by two methods. Yeah, direct branches, indirect branches. So facial artery is supplying the tonsil by direct branches and indirect branches. Indirectly, what it did was it was giving ascending palatine artery to supply the palate, which is the roof of the oral cavity. So to reach the roof of oral cavity, it was giving the ascending palatine artery, and it is a branch of facial artery. That ascending palatine artery supply the palatine tonsil because tonsil is in the palate. Okay. So who else is supplying the tonsil? You will see this is maxillary artery, and maxillary artery is giving a descending palatine artery. It is giving a descending palatine artery, and that descending palatine artery supplies the tonsil. Okay, so this DPA is descending palatine artery. Yes. And this descending palatine artery is a branch of the maxillary artery. Yes. Fine. So maxillary artery give descending palatine artery, and descending palatine artery also supply tonsil. Yes. So ascending palatine branch of facial artery, descending palatine branch of maxillary artery. Both of them supply tonsil. Yes. There is one more artery supplying. One more. Yes. Who is that? This lingual artery. Lingual artery? Yes. So lingual artery, I'll not show the branches reaching the tonsil, but you remember dorsal lingual arteries, branches of lingual artery also supply tonsil. So you are telling that the lingual artery, which is supposed to supply the tongue, is also supplying tonsil. Yes. And it is giving some dorsal lingual arteries. Yes. Okay. So now we have got this dorsal lingual artery, and dorsal lingual artery is a branch of the lingual artery. Yes. Supplying tonsil. So how many arteries have supplied tonsil? Number one, facial artery direct branch. Number two, ascending palatine. Number three, descending palatine. Number four, dorsal lingual, branch of lingual. And number five, ascending pharyngeal artery. So it is such a vascular tissue. Yes, that is why when you do tonsillectomy, you have to be careful. These arteries can bleed. So you have to ligate them properly. And there are few more which can supply. I'm not putting their names. There are others also which can supply. So five names you already have supplied, and there are more. Yes. Okay, but we should remember at least five of them. Right. Okay. So we have looked at the territory of external carotid artery supplying the tonsil, palatine tonsil. Yes. Okay. Now let us look at the subclavian artery details also, because there are some, it is important topic. So you draw the heart, and from the heart you give the arch of aorta, and from the arch of aorta you give three branches. So what are the three branches from the arch of aorta? We are having this first branch, brachiocephalic trunk, called so because it further divides into two, supplying arm and the head neck. So we are mentioning this is the heart giving the arch of aorta, giving three branches itself. First branch is called brachiocephalic trunk because it supplies brachium and cephalic region. Yes, name. The artery which is given to the upper limb is called as right-sided subclavian artery, right-sided subclavian artery. And the artery which is given to the head neck is right-sided common carotid artery, whereas left-sided common carotid artery comes directly from the arch of aorta, and so is the left subclavian artery to the upper limb. So the left subclavian artery to the upper limb is also coming directly from the arch of aorta. As we repeat the information, the heart is giving arch of aorta, giving three branches. The first branch is brachiocephalic trunk, called so because brachium and cephalic region is supplied. To supply the upper limb, right upper limb, it is giving the right subclavian artery. To supply right side of head and neck region, right head and neck region, it is giving right common carotid artery. And left common carotid artery comes directly from the arch of aorta, whereas left subclavian artery is also a direct branch of the arch of aorta to supply left upper limb. This is left subclavian artery. Now, these subclavian arteries, they are covered by muscle, and that is called scalenus anterior muscle. And the scalenus anterior muscle, which is inserting on the rib number 1, is dividing the artery into three parts: proximal to muscle, deep to muscle, and distal to muscle. I'll repeat. This subclavian artery is in the neck region covered by a muscle, scalenus anterior muscle. Subclavian artery may be on the left side or right side, both sides. So right and left side subclavian artery, they are covered by the scalenus anterior muscle inserting on first rib and dividing the artery into three parts: proximal to the muscle, deep to the muscle, distal to the muscle. So first part is proximal to the muscle, second part is deep to the muscle, third part is distal to the muscle. Same thing you show here on the right side also, right side. So on the right side, again, we are telling this is scalenus anterior muscle, and scalenus anterior muscle is inserting on rib number 1 and dividing the artery into three parts: proximal to muscle, deep to muscle, distal to muscle. Now, as we have mentioned it on the right side also, that this is scalenus anterior muscle inserting first rib and proximal to the muscle first part, deep to the muscle second part, distal to the muscle third part of subclavian artery. The first part is giving width branches. First part is giving width branches, And let us name them V, I, and T branches, width branches. So first part of subclavian artery, yeah, subclavian artery, first part, give the width branches. As you are telling, the first part of subclavian artery, which is proximal to the scalenus anterior muscle, is giving this V, I, and T branches. What is this V going upward? The V which is going upward is the vertebral artery, which you see here. You can write. The V is the vertebral artery, and it is going to supply the circle of Willis. So vertebral artery going to supply circle of Willis in the brain. Yes. I is coming down. It is called internal thoracic artery or internal mammary artery. It will supply the thorax and mammary gland. T is thyrocervical trunk, and it will supply thyroid gland and cervical region, the neck region. So as we are mentioning here, the first part of subclavian artery giving width branches, V going upward is vertebral artery supplying circle of Willis in the brain. Vertebral artery supplying circle of Willis in the brain. I coming down, internal thoracic artery supplying thorax as well as mammary gland on thorax. So it is also called internal mammary artery. You say internal mammary artery, you say internal thoracic artery, that is the one coming from first part of subclavian. And then this is the T, thyrocervical trunk supplying thyroid gland. So let us supply the thyroid gland now. It supplies neck region also. Let us supply thyroid gland now. And this is the thyroid gland. And thyroid gland is receiving this branch. You name the branch. It is called as inferior thyroid artery. It is called as inferior thyroid artery. And it is supplying the thyroid gland inferiorly. And whatever is happening on the right side will happen on the left side also. So symmetrical it is almost. Whatever you are showing on right side will happen symmetrically on the left almost same way. So this is inferior thyroid artery supplying the inferior side of thyroid. But inferior thyroid artery, which is a branch of thyrocervical trunk, which is a branch of first part of subclavian artery, not only supply the thyroid gland, it will also supply the parathyroid gland, which are behind the thyroid, the four of them. So this is superior parathyroid and inferior parathyroid. It supply them also. We are mentioning that inferior thyroid artery not only supply the thyroid gland, it also supply parathyroid gland, maybe superior parathyroid or inferior parathyroid. It supply all of them. Now we know the thyroid is kept in front of trachea. Thyroid gland is kept in front of trachea. So it supply trachea also. And behind the trachea, you have esophagus. It supply esophagus also. So I told you, inferior thyroid artery is very important artery. It supplies so many things. So what is it supplying? Respiratory tube and gut tube also. Which respiratory tube and which gut tube it is supplying? This thyroid is sitting on the front of trachea. And behind trachea, you have esophagus. So inferior thyroid artery supply thyroid, parathyroid, trachea, and esophagus. And it also supply thymus gland, which is actually in the superior and anterior mediastinum. Oh, inferior thyroid artery also supply thymus gland because it was moving with inferior parathyroid. That is why, if you remember, PP3 tip, pharyngeal pouch 3 gave thymus and inferior parathyroid. So PP3 tip, pharyngeal pouch 3 gave thymus, inferior parathyroid. As inferior parathyroid is being supplied by inferior thyroid artery, it also supplies thymus developmentally. Despite the fact that thymus has moved into superior mediastinum and anterior mediastinum. So maybe thymus lobes, they move into superior mediastinum, anterior mediastinum, but they are supplied by inferior thyroid artery, which was also supplying inferior parathyroid developmentally. So what all it has supplied? It has supplied thyroid, parathyroid, trachea, esophagus, and thymus. Okay. Do you remember it was also supplying recurrent laryngeal nerve? Do you remember it was also supplying recurrent laryngeal nerve? That is why we told inferior thyroid artery should be ligated as close as possible to thyroid gland so that it has already supplied recurrent laryngeal nerve and parathyroid gland. Then it was going to supply thyroid gland. then you ligate it. Oh, you are telling inferior third artery also supply recurrent laryngeal nerve. Yes. What if I ligate this artery away from the third gland? If you ligate inferior third artery away from the third gland, be prepared for recurrent laryngeal nerve ischemia and parathyroid ischemia and whatever it was supplying ischemia. Okay, so such an important artery. Yes. Do we have superior third artery also? Yes, you already know it. Who is that? Who is giving that branch? Right common carotid artery will continue as right internal carotid artery after giving the external carotid artery. Same thing happen here. After giving external carotid artery, the common carotid artery will continue as left internal carotid artery. So, as we are telling, the common carotid continue as internal carotid after giving external carotid artery. Or you can say common carotid bifurcate into two branches, namely external carotid and internal carotid artery. It is the same thing. So common carotid continue as internal carotid artery after giving external carotid artery. Or you can mention that it is the common carotid bifurcating into two branches, maybe external and internal carotid artery. But the first branch of external carotid artery was superior third artery. So superior third artery is the first branch of the superior thyroid artery is the first branch of the external carotid artery. And 10% people can have a third artery to thyroid. 10% people can have a third artery to thyroid, which is called as thyroid ema artery. So thyroid ema artery is present in 10% people, and it is the third artery to thyroid. Where is it coming from? It has variable origin. What do you mean by variable origin? It may come from brachiocephalic trunk, or it may come from arch of aorta, or it may come from some other source also. So you are talking about the thyroid ema artery, which is present in 10% people, the third artery to thyroid. Thyroid ema artery, which is present in 10% people, the third artery to thyroid is having variable origin, could be a branch of brachiocephalic trunk or arch of aorta or anything else. Yes. So can you show that in the diagram? Yes. And as you see the diagram, we are showing it coming from the brachiocephalic trunk because that is the usual thing, but it can also come from arch of aorta. So you are mentioning that this is the thyroid artery, yes, which is usually coming from brachiocephalic trunk, but may also come from arch of aorta. Yes, actually it has variable origin, but first answer should be brachiocephalic trunk. So this is thyroid ema artery. Yes, third artery to thyroid, right? Now this is the third artery to thyroid. I think it will be running in the midline. Yes, it is running in the midline. That is why when you do ischemectomy for tracheostomy, this artery may bleed. So be careful about that, though it is present only in 10% people. So since thyroid ema artery is coming from brachiocephalic trunk or maybe arch of aorta, it is running in the midline. And when you do ischemectomy to put a tube into tracheostomy, for doing tracheostomy, you have to cut the isthmus of thyroid and then you put a tube into tracheostomy. That time, be careful, you are putting a midline incision on isthmus of thyroid. You should not damage this artery. Otherwise, patient is already having breathing problem. Now the patient will have bleeding problem also. Artery will bleed. So already breathing problem is there. That is why you are putting a tube into trachea. And now the patient is having bleeding problem because of bleeding thyroid ema artery. Came as a question, in emergency tracheostomy, which structures are at risk of injury? In emergency tracheostomy, which structures are at risk of injury? Thyroid ema artery or inferior third artery? Thyroid ema artery or inferior third artery? You say thyroid ema artery. Why not inferior third artery? Because it is thyroid ema artery which is in the midline, not the inferior third artery. Your incision is in the midline. So midline artery will be affected, which is thyroid ema artery, not the lateral artery, which is inferior third artery. So this is at risk of injury in emergency tracheostomy, thyroid ema artery. With all that information, okay, you are asking about thyroid ema artery, dream, INI. Yeah, it supplies isthmus. That is correct. So thyroid ema artery does you're asking about external carotid or thyroid ema artery? Thyroid ema artery supply the isthmus. That is true. Thyroid ema artery supplies the isthmus. That is true. That is correct. But thyroid ema in 10% people only. Yes, Deepak, it is present in 10% people only. So that is again a problem because you may have done some 100 tracheostomy and you are so confident that 101 tracheostomy you were doing and now there's blood. You forgot that there could be an aberration because it is only in 10% people. That is more dangerous because you have not encountered it anytime and you're so confident you were doing the isthmectomy and then this artery bleeds. So you have to be careful, maybe 10% only, but you have to be careful. Maybe the patient you have is the patient in 10% population category. So having 10% is more dangerous because you may be confident that, okay, usually it is not there, but then it was there. So as a surgeon, you should be careful. Yeah, Pragati, we should take a break. And but before that, you should answer the questions. Okay, I think yeah, let us look at the questions. And that will be the end of head and neck region discussion. But then this diagram you see, page number 114. Page number 114. So as you look at this diagram, first of all, you should start with common carotid artery bifurcating into two branches, internal carotid, external carotid. External carotid giving three anterior branches. Three anterior branches on page number 114, you have this diagram. So the three anterior branches, we know this is the first branch, superior thyroid artery. This is the first branch, superior thyroid artery. This is the second branch, which is lingual artery. This is the third branch, which is facial artery. And facial artery is quite tortuous on face. So I'll repeat the information. This is common carotid bifurcating into internal carotid and external carotid. External carotid will give three anterior branches, 1, 2, 3. This is superior thyroid artery, the first branch of external carotid. That is second branch, lingual artery to the tongue. There's a third branch, which is facial artery. We want to talk about the facial artery, which is quite tortuous branches on the face. It is giving inferior superior labial artery to the lip. It is giving inferior superior labial artery to the lip and lateral nasal artery to the lateral nose and giving angular artery to the medial angle of eye. Remember these branches of facial artery. So facial artery, which is the third anterior branch of external carotid artery in sequence. Facial artery, which is the third anterior branch of external carotid artery in sequence. It is running tortuous course on the face, supplying upper lip, lower lip by labial arteries, upper and lower, supplying lateral nose by lateral nasal artery, and middle angle of eye by angular artery. Now you see there are some dorsal nasal artery, supratrochlear, supraorbital artery. Where are they coming from? This dorsal nasal artery, supratrochlear, supraorbital artery, they come from ophthalmic artery. And where is ophthalmic artery coming from? Ophthalmic artery itself is coming from the internal carotid artery. And where is internal carotid artery itself coming from? You see, this is the internal carotid artery. It comes from common carotid artery. Yes. So you are telling dorsal nasal artery and supratrochlear supraorbital artery, they are branches of ophthalmic artery, which itself come from internal carotid artery, which was given here. Yes. Internal carotid artery is supplying circle of Willis in the brain. Internal carotid artery supplies circle of Willis in the brain. It doesn't give any more branches here. It will give branches in the cranial cavity. So as it is giving branches in the cranial cavity, it will supply the brain, circle of Willis. It also gives ophthalmic artery to the orbit. And ophthalmic artery, which is a branch of internal carotid artery, gives supraorbital, supratrochlear, dorsal nasal. The point is, there's anastomosis here. And this anastomosis is between external and internal carotid artery branches at the medial angle of eye. So at the medial angle of eye, you are having the anastomosis of branches of external carotid and internal carotid, can provide some collateral circulation in emergency. It can provide some collateral circulation in emergency. Now, one other thing which you notice is this maxillary artery is supplying the lower teeth by giving inferior alveolar artery. This maxillary artery, terminal branch of external carotid artery. So this maxillary artery, which is terminal branch of external carotid artery, is giving inferior alveolar artery, which will enter the mandibular foramen to run inside the mandible bone and supply lower teeth. Lower teeth. So maxillary artery supplying lower teeth by giving inferior alveolar artery, which will enter the mandible in the mandibular foramen, run inside the mandible, come out of mandible here at the chin as mental artery and supply the chin. This mental artery, which is supplying the chin, is a branch of inferior alveolar artery, which supply the lower teeth, is a branch of the maxillary artery. That you remember. So on the face, mostly it was facial artery branches, but on the chin, mental artery is a branch of the maxillary artery. That you remember. Mental artery is a branch of inferior alveolar artery, is a branch of maxillary artery. That you remember. This is one thing. And second thing, you look at this question, which is not a branch of facial artery, page number 113. So as you look at this question, page number 113, you already have discussed the detail. It is asking what is not a branch of facial artery. You say it is the mental artery, because mental artery is a branch of inferior alveolar artery, which itself is a branch of the maxillary artery. So maxillary artery will give this and it will give this. So that is the answer. Lateral nasal is, of course, facial artery. Superior labial, inferior labial, facial artery. No problem. So number B. And yes, mental is maxillary. And then you will see this diagram, which we have drawn already, but it is kind of a repeat information, page number 117. So as you come to page number 117, you'll find this diagram. We already have drawn arch of aorta, 3 branches. In the 3 branches, first is brachiocephalic, second is the left common carotid, third is the left subclavian. Left subclavian and the left common carotid come directly from the arch of aorta, whereas brachiocephalic trunk is the first branch of the arch of aorta, called so because it will supply brachium and the cephalic region. Brachium and cephalic region. For brachium or upper limb, it will give the first, this right subclavian artery, supplying right upper limb, and the other one is common carotid artery on the right side, supplying head and neck region. Now, first part of subclavian artery gave width branches. In the width branches, T is thyrocervical trunk. The first part of subclavian width branches, the T is thyrocervical trunk, and thyrocervical trunk gave inferior thyroid artery to thyroid. Maybe from this side or this side, this is inferior thyroid artery, which is coming from the first part of subclavian. First part of subclavian gave width branches. In the width branches, the T is thyrocervical trunk, and thyrocervical trunk will give the inferior thyroid artery. Inferior thyroid artery not only supply the thyroid gland, it also supply parathyroid gland. It supply this trachea. It supply the esophagus behind trachea. It also supply the thymus. It also supply recurrent laryngeal nerve. So the inferior thyroid artery supply the thyroid gland, parathyroid gland, recurrent laryngeal nerve, the trachea, the esophagus, the thymus. And as you follow the common carotid artery upward, it will bifurcate into 2 branches, that is internal carotid, external carotid. External carotid, the first branch is superior thyroid artery supplying the thyroid gland on this side, that side also. So left-sided common carotid artery coming from directly from the arch of aorta is bifurcating into 2 branches. Internal carotid, external carotid. External carotid give first branch, which is superior thyroid artery supplying thyroid. And then there's a third artery to thyroid, which is thyroid ema artery. This thyroid ema artery, which is third artery to thyroid, present in 10% of population, is a midline artery. As you asked, it is supplying the isthmus. Yes, see here. It is supplying the isthmus. and it is a midline artery. So when you do isthmectomy to put a tube into trachea, which is behind the isthmus, if you cut the isthmus to put a tube into trachea, this artery may bleed. Is a branch of shown here as brachiocephalic trunk. Here it is coming from brachiocephalic trunk, which is usually the case, but it may also come from arch of aorta. It may be a branch of arch of aorta. First answer, brachiocephalic trunk. Second answer, arch of aorta. This is about thyroid artery, the third artery to thyroid. And once you have this information, okay, so you are asking, sir, maxillary artery branches needed for XM. What is XM? Maxillary artery branches needed for XM. Exam. Okay, exam. Okay. Yes, they are needed. Especially artery supply to Little's area of epistaxis. Arterial supply to Little's area of epistaxis. I'll quickly tell. Okay, don't worry. I'll tell this. But before that, let us just finish off this. And it is finished almost. You have to take care of this question on page number 116. Page number 116. I'll talk about this maxillary artery branches to Little's area of epistaxis. That is important. So, inferior thyroid artery supplies. And, yes, Akshay, Akshay, Sudhansh, Deepam, Alisha, Deepak. So, it is esophagus behind the trachea. Esophagus and trachea both it will supply. Supply thyroid and parathyroid. Supply thymus, add one more, recurrent laryngeal nerve. Add one more, recurrent laryngeal nerve. So, this is quite important artery. And it is supplying esophagus behind trachea. Both it is supplying respiratory tube, gut tube, thyroid, parathyroid, thymus, plus recurrent laryngeal nerve. So, all of them. C is the answer. And about the Little's area of epistaxis, quickly we can discuss. So, as you know, this is the external carotid artery. External carotid artery is giving two terminal branches. One of that is maxillary artery. This maxillary artery has three parts. Part 1, Part 2, Part 3. You already know the branches of Part 1. We have discussed. It was inferior alveolar artery, which was giving us mental artery. Mental artery. It was supplying the lower teeth, but it also supplied the upper teeth, the maxillary artery. This branch, middle meningeal artery. The middle meningeal artery, which was passing the foramen spinosum, bleed, anterior division, fracture pterion, giving extradural hematoma, if you remember. So, external carotid artery gave maxillary artery as a terminal branch, one of the terminal branch. It has three parts, 1, 2, 3. Three parts, 1, 2, 3. Part 1 gave two branches, one ascending, one descending. Part 1 of maxillary artery gave two branches, ascending, descending. Descending branch was passing into mandible. It passes in the mandible at mandibular foramen. Using mandibular foramen, it will enters mandible. So, as we are telling, this is the external carotid artery giving two terminal branches. One of the terminal branches, maxillary artery, supplying the bone maxilla, of course, has three parts. First part giving two branches, one descending. The descending one, which passes mandibular foramen to enter the mandible, is called as inferior alveolar artery. This is inferior alveolar artery. And inferior alveolar artery later gave mental artery to supply the chin. It also supplies lower teeth. But this artery also supplies upper teeth. How do you supply the upper teeth? For upper teeth, it will give superior alveolar arteries. Superior alveolar arteries. And as it gives superior alveolar arteries, it will also supply upper teeth. So who is giving this superior alveolar artery? Third part of maxillary artery. Third part of maxillary artery. So you're telling that the lower teeth are supplied by first part. Yes. And upper teeth are supplied by third part. Yeah. First part of maxillary artery supply lower teeth by giving inferior alveolar artery. Third part of maxillary artery supply upper teeth by giving superior alveolar artery. But we wanted to talk about Little's area of epistaxis. So if you remember, it gave a branch descending palatine artery. Descending palatine artery, which was supplying tonsil also. Descending palatine artery gave a branch which is called as greater palatine artery. It is important for nose. So I'll repeat, from the third part of maxillary artery. From the third part of maxillary artery comes descending palatine artery, which supplied palatine tonsil. Descending palatine artery supplying palatine tonsil. This descending palatine artery gave greater palatine artery, and greater palatine artery supply nose. When I say nose, it will supply Little's area of epistaxis also. It will supply Little's area of epistaxis also. But the major artery to the area of epistaxis is again given by third part of the maxillary artery in the pterygopalatine fossa, which is also called sphenopalatine fossa. Artery is called sphenopalatine artery, and it is the artery of epistaxis. It is the artery of epistaxis. So, sphenopalatine artery, which is given in the pterygopalatine fossa, which is also called sphenopalatine fossa. So, as we understand, third part of maxillary artery has supplied the upper teeth by giving superior alveolar arteries, upper teeth. It also gave descending palatine artery to supply palatine tonsil, but descending palatine further gave greater palatine. And remember, greater palatine also supply the nose, Little's area of epistaxis. Even greater palatine artery supply nose, Little's area of epistaxis, but the major artery is coming from third part of maxillary artery only. In the pterygopalatine fossa or sphenopalatine fossa, the name is sphenopalatine artery, and it is the artery of epistaxis. It is the major artery to the Little's area of epistaxis. So, if you were asking about maxillary artery branches, I have given you the maxillary artery branches. They are important actually. They are important, especially for the Little's area. Okay. So we'll take a break now. It is already 5 p.m. So, yes, team, welcome always. So it is already 5 p.m. I think because I have to take a lot of 3-hour session. Yes. Great, Rahul. So as I have to take a lot of screenshots, so 15 minutes is less. Let us take 20 minutes break. Anyway, as Rahul is telling, we did 3-hour session. So 15 minutes become 20 minutes. We'll come back at 5:20. Okay. No, 5:30. 5:20. 5:20.